members of the Urological Society of East Zone chapter for cordially and wholeheartedly supporting this academic session. Mm, I personally request the coming generation to utilize the effort that has been given by these senior teachers. And with this small introduction, today's teachers and the moderators and the chairpersons do not require any introduction to the members of the Urological Society. Only for the interest of the students, I can only say Professor Hota, who was one of the mentor urologists in the eastern zone of this eastern part of this country, and we have a lot of hopes from him to see him in a much higher position in future. Presently, he is the principal of SCB Medical College, Cuttack, and at the same time, one of the very renowned urologists from this zone, Dr. Rajendra Sinam, who was the ex-director of the RIMS Imphal, and I don't think I am associated with this zone from 1994. I have not seen any conference without Dr. Sinam. That was the conviction and that was the attachment of that gentleman in this society. And Dr. P.K. Mishra, my senior boss, and Dr. Cornell is also there. Has he joined?
Nandi has not yet
Yes,
joined.
Colonel Nandi
Yes,
has
sir,
joined.
I have joined. I am joined, sir.
Oh, that's good. That's
So
good.
yes,
Colonel is always on time.
Cornell,
That's
Dr. Cornell, all of you, today, I must say it's a very least practice and least projected aspect of the urology. That is why I have chosen the best of the persons. And with us today, Dr. Bhasan, we will. Has he joined? Has he joined, Dr.
Dr.
Bhasan?
Vasan sir hasn't joined. He is joining, sir.
Okay, sir. Dr. Bhasan, who is one of the national and the internationally famous andrologists, this conglomeration of the galaxy of stars today is conducting a session to popularize and also give the brief idea about the andrological practice for the students. With this small introduction, I hand it over to Dr. P.K. Mishra and Dr. Professor Hota to conduct this session with his galaxy of teachers and the students. Thank you very much, sir.
Thank you very much. I believe we'll open it with Dr. Hota's comments and opinion as well as the guidance. Dr. Hota, please.
Am I audible?
Yes, sir.
Yes, sir. You are audible.
You are
Loud
audible,
and clear.
sir.
No, you are not audible.
No, he is audible.
Is he?
I could
You
hear
are
him.
audible, sir.
Good.
Hello.
Sir, your voice is not coming right now.
না না আমি পাচ্ছি লোকেরা পাচ্ছে
Is Dr. Hota audible? We've lost Dr. Hota, I believe.
Am I audible now?
Yeah, you are audible.
Yes, sir,
now.
you are
Loud
audible
and
now.
clear.
So I was trying to use my headphone and I am not that technically savvy. Well, good morning to all my esteemed colleagues. And thank you, Dr. Ranjan, for the good words. In fact, andrology as a subspecialty among all the subspecialty of urology that we have has not grown the way we would expect it to grow in our zone. And thanks to the organizer, particularly to the office bearers of the zone, and especially to Dr. Ranjan for taking this opportunity, taking the society quite forward and utilizing the time also for the andrology. And as you know, now the USI also has got six subsection, and andrology is one among them. Now, whatever we are now going to do, all these subsections will have its independent function even though the umbilical cord tied to the central body. Now, each section will be functioning independently as regard their academics are concerned, as regard the annual functions are concerned. And what I am told, given to understand, that all these subsections will be a day's program in the national conference hereinafter from 2023. Now, we in ISJON need to definitely establish andrology as a subspecialty and to be known to the rest of the country. Now, a lot of things has developed over the years in andrology, but during our learning period, during our postdoctoral courses, we have not given due importance to this subspecialty. It is only information to all that those who are, going to become urologists or young urologists. NB is starting a fellowship course for 2 years in andrology from this year. So one can pursue a career in andrology from now onwards. Today we have got so many speakers to highlight about the different aspect of andrology. I am pretty sure that there will be lot of gain out of this program, and I look forward that andrology is established definitely in our zone. Now, one more thing I would like to convey through this forum, that the andrology subsection meeting is going to be held on 10th and 11th in Konark. That the andrological subsection is conducting it. We have already chalked out the detailed program. Anybody who is interested can join. Only thing that I would request all the members, the full members of the USI, to become a member of the Urological Society of India Andrology subsection. Kindly go to the website. You can log in and you register yourself as a member. Now, with these few words, I would hand over to Dr. Mishra and others to start the proceedings. And as the proceedings goes on, we can interact on this subject. Thank you, and hand over to Dr. Mishra, please.
Thank you very much, Dr. Hota, for this direction that you have given to this subspecialty, especially in our zone. So without spoiling much time, we'll get along with the program. There's a long program, a lot of speakers. I will request all of them to please stick to the time. Am I audible?
Yes, sir.
So I will request all of them to please stick to the time. As it is customary, any subjects begins its discussion with anatomy and physiology. And for this, I will invite Dr. Vishal Jalan. He's a student, MCH student, to give a talk on the anatomy of the genital tracts of genital tract with special relevance to the surgeries. So is Dr. Jalan here?
Good morning, sir.
Yeah.
Good morning, sir. I am Dr. Vishal Jalan,
Please
sir.
introduce yourself. Please
Sir,
introduce
I am
yourself.
Dr. Vishal Jalan. I am a third-year resident from IPGMER, Kolkata, sir.
Yep,
Dr.
carry on. Carry on.
Go ahead. Go
So
ahead.
carry on, you share your screen and carry on with your talk. Please stick to the time.
Sir, is my screen is visible, sir?
Yeah,
Yes,
yeah.
it's visible, very clear. Make it full screen, please.
Yes, sir. Yes. So is it full screen now?
Yeah, it's full screen.
My voice is audible, sir?
Yes, it's audible.
Yes, sir. Shall I start, sir?
Please.
Yes, sir. Good morning, everyone. I am Dr. Vishal Jalan, a third-year student from IPGMER, Kolkata. Today, my topic of presentation is on anatomy of male reproductive system. Now, the male reproductive system is a network of external and internal organ that functions to produce, support, transport, and deliver the viable sperm for reproduction. It comprises of testes, accessory ducts, glands, and the penis. Each of the organ I will discuss individually. Now, first one is the testis. We all know that it is a paired organ that lies within the scrotum, having a dimension of about 4 to 5 centimeter in length, 3 centimeter in width, and 2.5 centimeter in the breadth, having a volume of about 15 to 20 ml. 25 ml. It is enveloped from outside inward by tunica vaginalis, albuginea, and vasculosa. Now, this tunica albuginea, it from the postolateral aspect invaginates the cavity of the testis to form mediastinum testis. This mediastinum testis gives the septa to the inner surface of the tunica vaginalis to divide this testicular cavity into 200 to 300 lobules. This lobule contain one or more of the seminal seminiferous tubule which coil upon itself, and at the apex of these lobules it becomes straight to drain into the retitestis. The retitestis is the network of this seminiferous tubule joined with each other, and from this retitestis arises the efferent ductule. There are 12 to 20 efferent ductule that leaves the testis and become convoluted, enlarged, and form conical lobules, at which is we known as a head of the epididymis. It is at this place they join with each other to form a single duct, the epididymal duct, which winds to form the body and the tail of the epididymis. Apart from this seminiferous tubule, the testicular cavity also contains the interstitial space, which makes about 20 to 30% of the testicular volume, in which there are vessels, nerves, lymphatics, and the one more important thing is the Leydig cells. This cell is very important because it produces the testosterone. Now coming to this seminiferous tubule, this seminiferous tubule is internally lined by Sertoli cells, and interspersed between this is the germinal epithelium. This Sertoli cell is very important not only because they give nourishment to this growing spermatozoa, but also it forms a tight junction by binding with each other. And because of this tight junction, it is known as blood testis barrier. This spermatogenesis process, as we know, is the immunologically privileged organ, tissue, meaning that this tissue never come in contact with the immunological system. So whenever the immunological system found this germinal epithelial cells, they consider it to be the foreign body and produce antibody against this. This is we known as anti-sperm antibody, which have a role in infertility. Now coming to the vascular supply of the testis, we all know that it is supplied by three vessels, mainly the testicular artery, which is directly a branch of abdominal aorta. Apart from testicular artery, we have vessel artery and the cremasteric artery. Now the vascular drainage, the venous drainage is very important. All the veins from the testis, epididymis, and the vas deferens combine to form pampiniform plexus. This pampiniform plexus surrounds the testicular artery and help in the counter current heat exchange mechanism. It is because of this heat exchange mechanism that testicular temperature is relatively lower than the rest of the body, making the testis a comfortable environment for the spermatogenesis. It have a role. When we see the varicose vein, this counter current heat exchange mechanism get hampered. Because of this, the testicular temperature become almost to the temperature of the body, and the spermatogenesis process get slowed down or hampered. This pampiniform plexus in the inguinal canal join with each other to form 2 to 3 veins, and it leaves the internal inguinal ring becoming a single vein. On the right side, the gonadal vein drains into the IVC, and on the left side, it drains into the left renal vein. The lymphatic drainage is very important so far as the carcinoma of the testis is concerned. The right testis drain into the interaortocaval and the paracaval group of lymph node, and the left testis drain into the para-aortic group of lymph node. In the retroperitoneum, it have a blood lymphatic supply from right side to the left side. Now coming to the epididymis, it is a coma-shaped structure like postolateral to the testis. It is a tightly coiled tubular structure. When stretched, it becomes 3 to 4 meters in length, having the three parts. The caput part, which is formed by the efferent ductuli that I have already told. This joint to form efferent epididymal duct, which coils to form this corpus and the cauda. This have importance because it helps to give the motility and the maturation of the sperm. Now, the microscopic anatomy of this epididymis is mainly the stereocilia. This stereocilia lines the internal lumen of the epididymal duct. It helps in the movement of this sperm from proximal to the distal side. And the artery venous supply is similar to that of the testicular artery, testis. Now coming to the vas deferens. Vas deferens is a white, shiny, tubular structure that we have all felt during the hernia surgery. It travels behind the vessels in the cord, and through the inguinal canal, it reaches the pelvis lateral to the inferior epigastric vessel. That is the deep inguinal ring. At the level of deep inguinal ring, it gets separated from the testicular vessels and turns a infromedial course to lie on the posterior base of the prostate. It is totally about 30 to 35 centimeter in length, and according to the place where it is divided into 5 regions: epididymal region, scrotal region, inguinal region, retroperitoneal and ampulla region. Now it is from outside inward lined with the connective tissue layer which contain the blood vessels and the nerves. And the smooth muscle, it have a very thick smooth muscle having a three layers, outer longitudinal, middle circular and inner longitudinal, and is lined by the pseudo-stratified columnar epithelium with non-motile stereocilia. The cell height decreases as we go from proximal to the distal. It is supplied by the differential artery, which is the branch of the superior vesical artery, and the scrotal segment of the vas is drained to the tympaniform plexus, and the pelvic segment drained into the pelvic venous plexus. Now coming to the seminal vesicle, it is a paired viscous organ that lie posterior to the bladder base and the prostate. It is generally, we know that it is a lateral outpouching of the vas deferens having a capacity of 3 to 4 ml. In the unobstructed seminal vesicle, we found a length of about 5 to 7 centimeter and a width of about 1.5 centimeter. It joins with the ampullary portion of the vas deferens to form ejaculatory duct. Now this ejaculatory duct is divided into three parts according to the relation of it with the prostate, which is extraprostatic region, which is outside the prostate, intraprostatic region, inside the prostate, and the distal region, which is there in the verumontanum. Now it is supplied by the superior vesical artery, which is divided to give the vesicular differential artery and supplies the anterior surface of the seminal vesicle. Now ejaculatory duct is supplied by the inferior vesical artery. Now coming to the prostate. Prostate is a ovoid structure having a 3 centimeter in length, 4 centimeter in width, and 2 centimeter in depth. In a young healthy male, it is about 18 to 20 gram in weight, composed of the glandular tissue and fibromuscular stroma. It lies below the prostate in front of the rectum, lies on the urogenital diaphragm, and attached to the pubic bone by puboprostatic ligament. It is divided into the different zones. The first we discuss the transition zone, which makes about 5 to 10% of the glandular tissue of the full prostate. It is important because here the benign prostatic hyperplasia develops. Postolateral to it lies the central zone, which makes about 25% of the glandular tissue, and postolateral to that is the peripheral zone, which makes about 70% of the glandular tissue, and also the most common site for prostatic carcinoma to develop. Anteriorly, we have the anterior fibromuscular stroma, which doesn't contain any significant glandular element, but contains the collagen, smooth muscle, and the elastin. As we all know that the prostate develops from the urogenital sinus. From the urogenital sinus arises the prostatic bud, which divides primary, secondarily, and tertiary to form prostatic acinus, which is lined by the epithelium. This epithelium secretes their product directly into the prostatic urethra by these prostatic ductules, which open on the prostatic sinus, which is on the either side of the urethral crest. The stoma is composed of the smooth muscle that is rich in actin, myosin, desmin, and composed of the collagen. Now coming to the arterial supply, it is very important to know the arterial supply of the prostate because it is by the inferior vesical artery that divides into urethral artery and the capsular artery. This urethral artery runs perpendicular to the urethra, and when it comes to the neck of the urethra, it turns right angle turn to supply the urethra, periurethral gland, and the transition zone. Now this capsular artery, which is a continuation of the inferior vesical artery, run along with the cavernous nerve and the vein to form a neurovascular bundle lie on the posterolateral groove of the prostate. It is very important to preserve this nerve while doing the nerve sparing radical prostatectomy or radical sister prostatectomy to prevent the patient to develop to prevent the development of erectile dysfunction. The venous drainage is, as we all know, that deep dorsal vein of the penis drain into the deep dorsal venous complex, and from there it forms the periprostatic venous plexus. The lymphatic drainage is important. So far as the prostatectomy is concerned, it drains into the ocular and internal iliac group of lymph node mainly, and some part drain also the external iliac and to the presacral group of lymph node. It is supplied by the cavernous nerve that I have already told, that this cavernous nerve gives the autonomic innervation to the prostate. The sympathetic supply is to the smooth muscle of the prostate, and the parasympathetic gives secretory function to the terminal acini. Now urethra, the part which is from the bladder neck to the external urethral meatus, we know is the urethra. The anterior part, it is divided into two components, anterior urethra and the posterior urethra. This anterior urethra completely surrounded by the corpora spongiosa, and the part proximal to it is the posterior urethra. From bladder neck to verumontanum is the prostatic urethra, and distal to it before the perineal membrane is the membranous urethra. Now coming to the prostatic urethra, this urethra transfers the full length of the prostate towards the anterior zone, and posteriorly it invaginates to form the urethral crest. On either side of this urethral crest is the prostatic sinus that I have already told that from here to this area, the prostatic duct of the gland gets drained. This urethral crest get enlarged in the distal portion to form verumontanum, at the apex of which drains the prostatic ureticle, and on either side the ejaculatory duct. Now the membranous urethra, it is about 2.5 to 2 to 2.5 centimeter in length and lie in the deep perineal pouch and is surrounded by the external sphincter, which is not the circular sphincter but rather a horseshoe shaped with the limb attached to the perineal body. And at this level also lies the bulbourethral gland, the copper gland. Now coming to the penile urethra, I have already mentioned that proximal part is known as the bulbar urethra. It is from the perineal membrane till the suspensory ligament of the penis. It is important in two sense that corpus gland duct drain at the 3 and 9 o'clock position. Not only this, the complete anterior urethra is surrounded by the corpus spongiosum, and outside of this spongiosum, the bulbar urethra is also surrounded by the bulbospongiosus muscle, which is very important for the ejaculation of the semen that is placed here in the emission phase of the ejaculation. And the penile urethra is 15 centimeter in length and lined by, and posterior surface is lined by the Leiter's gland, which secretes the mucus to lubricate the urethra before ejaculation. The fossa navicularis is the granular portion of the urethra where its caliber get dilated compared to the proximal part and narrows again to drain into the external urethral meatus. This part of the urethra is lined by the squamous epithelium and it becomes keratinized near the meatus. Now coming to the penis. Penis is a cylindrical structure contain the two corpora cavernosa, which is separated by a thin septum, which at distal area get permeable so that these two corpora cavernosa act as a single unit. Proximally, these corpora cavernosa get bifurcated to form the crust of the penis and attached to the inferior pubic rami. At this place, they are surrounded medially by the ischiocavernosus muscle. This ischiocavernosus muscle is very important for the erection because contraction of this causes the hard erection, the rigid erection of the penis. We have 7 stages of penis, which will be discussed later on by my other colleagues. Now, the corpora cavernosa is surrounded by the tunica albuginea. This tunica albuginea is the tough layer. It is a bilayer having inner circular and the outer longitudinal layer. This layer is so tough that it holds the several hundred pressure of the mercury pressure of the corpora cavernosa that is there in the during the erection, and it also helps in the veno-occlusive mechanism of the initial phase of the erection of the penis. It is deficient in 5 and 7 o'clock position. Now the penile shaft skin. Penile shaft skin is very elastic and is very mobile because it attaches to the dartos, which itself got loosely adherent to the Buck's fossa. And the glans penis is not mobile because it is directly attached to the tunica albuginea. Now coming to the cross-sectional anatomy of the penis, from outside inwards, it is very important to know the layers of the penis, which is skin, dartos, Buck's fossa and tunica albuginea. This Buck's fossa is very important because anything that is outside the Buck's fossa is the superficial system, and anything deep to this Buck's fossa is the deep venous system. We can clearly see here that the deep dorsal vein of the penis lie in between the two corpora cavernosa, and lateral aspect of this is the dorsal artery, and lateral to this is the dorsal nerve. This is the nerve we block during the circumcision, penile block. Now coming to the arterial supply, it have a 2 arterial supply. The superficial arterial system outside the Buck's fossa supplies by the external pudendal artery, and the deep arterial system is supplied by the internal pudendal artery. Now this internal pudendal artery, after giving the middle lateral artery, runs in the Alcock's canal that is there in the lateral pelvic wall, and it is from there it supplies give first branch to the bulbospongiosus muscle, bulbourethral artery. This artery we commonly encounter during the progressive perineal urethroplasty. It supplies the bulbospongiosa, and this internal pudendal artery runs, common pudendal artery runs and give the cavernosal branch which supply the corporal sinuses and run distally as the dorsal nerve of dorsal artery of the penis. We supply the dorsal surface of the corporal body and give these circumflex branches. These circumflex branches are very important because it makes the bulbospongiosus a dual blood supply carrying structure, and it is very important to preserve this artery during the urethroplasty, as we see in the Kulkarni technique, which have an advantage over the Barbagli technique. Now coming to the venous drainage, I have already told that anything superficial to the bucks is the superficial system. The superficial dorsal vein of the penis is external to the bucks fossa, and deep to the buck fossa is the deep dorsal plexus. And as we have see that these venous tributaries join at the dorsal aspect of the penis at the corona to form deep dorsal vein of the penis, which run between the two corporal body and drain into the preprostatic plexus. At the distal two-third, it is drained by the circumflex veins, which drains the corpus spongiosum. This is very important. Why? Because it receives the emissary vein from the subtunical plexus that drains the corporal sinuses. And as we see in the erection, these corporal sinuses got enlarged and give tunical stretching. And this stretching causes the emissary vein to get compressed. And this is the basis of the veno-occlusive form of the initial erection of the penis. Coming to the lymphatic drainage, the skin of the shaft and the prepuce drain into the superficial inguinal group of lymph node, and the glans and the corporal body drains into the superficial and deep group of lymph node. There is a multiple crossover at the different level, so that each lymphatic can drain either of the side. And we know that the nerve supply of the penis is from the dorsal nerve of the penis, which is nothing but the continuation of the pudendal nerve, and the autonomic innervation of the penis is from the cavernous nerve that I have shown that lie in the posterolateral group of the prostate as a neurovascular bundle. Now coming to the scrotum. Scrotum is a multi-layered cul-de-sac like structure that lies behind the penis and in front of the anus, and it is having a skin which is very tortuous and having a hair bearing and pigmented and contains multiple sweat and sebaceous gland, but this layer doesn't contain any fat. The median raphe is the raphe that runs all the way from the external urethral meatus till the anus. Deep to this raphe lies the septum, which divides the scrotum into the right hemiscrotum and the left hemiscrotum. Within this hemiscrotum lies the testis. And as I have told you that it is a multi-layered structure, meaning that it is layered by the several fascia. These fascias are nothing but the continuation of the anterior abdominal wall. Like external spermatic fascia is a continuation of the external oblique muscle, cremasteric is the internal, and the internal spermatic fascia is the fascia transversal is continuation. And this from outside inward is very important to know that it is skin, dartos, external spermatic fascia, the cremasteric fascia, the internal spermatic fascia. Deep to this lies the tunica vaginalis, which is nothing but the elongation of the peritoneum, which is having a two layer. The outside layer is the parietal tunica vaginalis, and the deep is the visceral tunica vaginalis. This tunica vaginalis is very important during the urethroplasty. It is the parietal layer that we take to reinforce the layer of the urethroplasty. Now the arterial supply, as we know that the scrotum is a cul-de-sac structure having the anterior surface and the posterior surface. This anterior surface is supplied by the external pudendal artery, which is nothing but the branch from the femoral artery, and on the posterior aspect it is supplied by the perineal branches. Now the venous system is also external pudendal vein, which drains into the saphenous vein, and the posterior venous drainage is to the perineal veins. The lymphatic is to the superficial inguinal lymph node. The nerve supply is very important because it is supplied by the ilioinguinal nerve, and the most important part is the genitofemoral nerve. It is the genital branch of the genitofemoral nerve that supplies the scrotum, and the femoral branch of it supplies the inner aspect of the thigh, and it is the nerve we check the integrity by doing the cremasteric reflux. Thank you.
Excellent. Dr. Jalan has done a very good job by finishing in time and has crisply covered the anatomy. So we move on to the next speaker, who is no less than Dr. Nandi. Just to give a brief introduction, since people might not be knowing him, he's a Lieutenant Colonel in Armed Forces. He did his MBBS and MS from AFMC Pune, and he did his MCS from BHU Banaras. He takes deep interest in andrology. And he has a lot of publications, and he has also authored certain books. with this short introductions, I will call upon Dr. Nandi to share his screen and go ahead with presentation, which is on infertility.
Good morning,
Dr.
sir. Am
Nandi.
I audible?
Yeah, you are audible.
I will just
Yes,
share
your
the screen, sir.
Screen is also in, just make it full screen.
Yes, sir. I'm just making it. Sorry.
I will just request you to stick to 25
Sir, I will
minutes.
just
Yeah, I know.
Just 1 minute, sir. Good morning, everybody. I am really thankful to Bengal Urological Association as well as the East Zone Urological Society to give me a chance in presenting on this topic. As I was preparing for the topic, I was told by Dr. Ranjan Deb that it is for the exam going students, basically. So I went through the questions, and as late as December 2021, in DNP, there was a question, long question on azoospermia. Am I audible? Hello, am I audible? Am I audible?
Yes, yes, you are audible.
Thank you,
You
thank
are
you.
audible, Dr. Nandi.
So there was a long question on azoospermia. So on that basis, we are just starting the presentation. As we all know, 15% of couples are unable to conceive after 1 year of unprotected intercourse. Here, one point is very important, that in case of infertility, the female age is very important. And so if female is more than 35 years of age, then this 1 year of unprotected sex is reduced to 6 months. The male factor is solely responsible in about 20% and is contributory to another 30%. So identification of the etiology of an abnormal semen analysis is not possible in approximately 30%, which is called as an idiopathic male infertility. Then the reason of infertility is not clear. And with a normal semen analysis and the partner evaluation, it is termed as an unexplained infertility, which is around 25% of cases. So evaluation, for initial evaluation, both male and female partners should undergo concurrent assessment. Because in almost 1 in 4 cases, it has been seen that the problem lies in both the partners. Should include a reproductive, medical, surgical history, physical examination. On this, in the sexual history, very important is an unconsummated marriage. This topic, unconsummated marriage, as an urologist, I never used to believe in it. But a lot of sexual medicine practitioners highlight this. And you won't believe, as I was going through the question papers, in 2018, in DNB, there was a question on unconsummated marriage. Once that I saw that question, I felt, yes, there is some importance. And in the books, almost 5 to 17% has been quoted as an incidence. And it is basically because of ignorance, illiteracy, inhibition, and all. But anyway, it is a question which has been here. And so unconsummated marriage, that history has to be taken, whether they're having the sexual intercourse properly or not. Lubrication history is very important because at times there is spermicidal and the frequency of intercourse. And then this S factors, smoking, stress, spirits or alcohol, swana. I made it so that the exam going people can remember. Physical examination, scrotum for the varicose testis, vas, and the DRE. My previous speaker has spoken about anatomy, these all are covered. Now the testis, one thing to important is that 4.6 centimeter long and 2.6 centimeter in width is taken as a standard EA and 18 to 20 cc volume. Here one small question for the exam going people. There is something called Meckham's maxim. It is basically, once you search for the vas, when you are palpating vas, you should search for the vas as if you are performing the first step of a vasectomy, bringing it to the surface of the skin. If what is presumed to be vas disappears from the examiner's fingers for the fingers 3 times, the clinicians can be confident that the vas is absent. This is called Meckham's maxim. It is just for the knowledge for the exam going people. It can be a question or anything, anytime, anywhere. And this is just for the measurement. All know, I just kept it. If you have a spot or anything, there's a Prater's orchiodometer and the Scaliper's Seeger's orchiodometer. Now, the semen analysis, which is still today the mainstay. The initial evaluation should include 1 or more semen analysis. They say that it should be more than some 3 to 4 weeks apart, but it is usually not possible. Previously, they were said that it should have a 3 to 5 days abstinence, but presently it is believed that for bulk seminal parameters, even a single day abstinence is good enough. Important thing to remember, 10% are unable to give sample because they either have not masturbated or they have inhibited to in a setting of the clinics, fail on demand. And the use of this, in those cases, one can advise for the home collection, but with a special non-spermicidal condoms, and at times the requirement, which I will cover, the use of vibrators and all in my, as I go ahead. Very important thing that the semen analysis has to be done within, it should be transported to the lab within 1 hour. It becomes very difficult. So a lot of work is being done to develop a media for the transport of this semen. And as we have Professor Dr. Vasan, his institute, Ankur Institute in Bangalore, they have prepared a Zapril, which in that case, it can be easily transported even up to almost 1 hour. Sorry, more than 24 hours, it can be easily preserved. So it's a very good development on this field. Previously, it was believed that shorter abstinence affected the concentration, prolonged abstinence affected the motility. But now, for bulk parameter, single day abstinence is good enough. Now, the abnormalities are broadly the seminal plasma abnormality and the spermatogenic abnormality. The seminal plasma abnormality, most important is the quantity. We will see whether it is a few drops or it is adequate, that is around more than 1.5 ml to 3 ml. pH. Previously, this pH was believed to be very important. pH was there, whether to see it is acidic or alkaline. Normal is around 7.2, slightly on the alkaline side because of this secretions on seminal vesicle. So in the case of obstructions, this part is not there, so it usually becomes acidic. Fructose. As a old timers, we were taught the importance of fructose, but these days, measurement of fructose is very difficult. And this Selvinov's test, which they say that 0.5 ml semen plus 5 ml results in all, will lead to color change. But usually, when these patients have a very low semen volume, this test becomes very difficult. So theoretically, they say that there is something called modified Selvinov, but practically it is very difficult. So the Selvinov's test is now not being done, and even the Campbell's Urology doesn't mention about fructose in its chapter on investigation of infertility. Another thing is the round cells, and which has to be differentiated for the immature germ cells and the leukocytes. Now, pH, as I said, that environmental conditions may alter it, and there is a vast difference between the size of the hydrogen ion and the sperm head. So the importance of pH is also gradually losing its importance. Now, the second broad area is the sperm abnormalities, 3 headings: concentration, motility, and morphology, and the degree of abnormalities. So WHO recommends that the seminal fluid can be centrifuged for 15 minutes at 3000 revolution. The semen should be examined in 1 hour, as I said, and within half an hour of liquefaction. So if unstained slides, one cannot differentiate between the precursor cells from other round cells, that is leukocytes or macrophages. So one has to confirm this by technical stain. Certain nomenclature related to 7 parameters. Just broadly, I have covered oligozoospermia when the total concentration is less than 10 million per ml, and severe oligospermia is less than 5 ml. Asthenozoospermia, if the percentage of progressive. Hello? Am I audible? Teratozoospermia, the percentage of morphologically normal spermatozoa is less than the reference limit. Cryptozoospermia, when the spermatozoa absent in the ejaculate but seen on centrifuged pellet. So in case of azoospermia, there is the importance of getting it centrifuged and then examining the pellets. So if the normal examination shows as azoospermia, but after the examination of pellets, there can be sperms. So that is the importance. Homospermia is the presence of erythrocytes. Leucospermia, that is presence of leukocytes, which has to be differentiated from immature germ cells. This is a very common mistake. Often they cite that leukocytes positive, but actually what they see under unstained slides is the round cells, and people give antibiotics, and this is a misuse. So this thing, and people interested in andrology should especially take care of this aspect. Though it is a very simple thing, but one should look into it. Leukocytes more than 1 million per ml, and only one should ask for an urine culture, semen culture, and even PCR for chlamydia, gonorrhea, etc. Right. Necrozoospermia, low percentage of live and high percentage of immotile spermatozoa. These are the sixth manual, which is broadly given it to normal, borderline, and pathological. Same, but concentration more than 20 million, borderline 10 to 20, less than 10, motility more than 50%, 35 to 49%, less than 35%. This is the total motility, and morphology more than 14%, 4 to 30, and less than 4%. So, causes of azoospermia, broadly, the testicular causes constitutes around 80% of the spermatogenic defects. Pre-testicular, around 8%, which is because of the disorder of hypothalamo, pituitary, and gonadal axis. So, most important is the hypogonadotropic hypogonadism and hyperprolactinemia. And now the post-testicular is another 12%, mainly epididymal dysfunction, any anatomical obstruction, or infection of the accessory glands, epididymis, urethritis, etc. Azoospermia and oncogenesis, I've just covered this thing because today with so many increasing cases of cancers and that also in young ages, so azoospermia is associated because it results from dysregulation of the molecular system. Inform patients undergoing chemotherapy and or radiation therapy to avoid pregnancy for a period of at least 12 months after completion of treatment. Encourage men to bank sperm, preferably multiple specimens when possible, prior to commencement of gonadotoxic therapy or other cancer treatment that can affect fertility in men. Clinicians should inform men seeking paternity who are persistently azoospermic after gonadotoxic therapies that they say is a treatment options. Now, the flow chart, this was the question also in the exam. The semen volume, as I said, firstly, the semen volume is very important. If it is normal, that is more than 1.5 ml, calculate the test is. If it is small, then do the FSH test, and on that basis, we'll go further. And if it is normal, again, the FSH is normal, and if the epididymis is thickened on palpation, then it is more likely that it is an ejaculatory duct obstruction. We will work accordingly. If there are few drops, so in that you try to palpate the vas. If the vas is absent, then one has to go for donor insemination or adoption. If the vas is present, then we further work up with the truss. Now, with the small testis, FSH, as I said, if the FSH is low, in that case, it is hypogonadotropic hypogonadism. We can think of LH and FSH replacement and sperm retrieval followed by ICSI. If it is high, in this case, it is more than twice the normal value, then it is primary testicular failure, sperm retrieval, and ICSI. In primary testicular failure, it has been seen that almost even in the 50 to 60% cases, there can be focal spermatogenesis. That is a very important point one should remember. Now, azoospermia, if there is a bilateral absence of vas, then advise the CFTR panel for the patient as well as the female partner. If it is not absent, semen volume, if less than 1 ml, then we do the post-ejaculatory urine analysis. If it is sperm is absent, then we do the trans ultrasound and evaluate for ejaculatory duct obstruction. If it is present, then it is retrograde ejaculation. So for doing this retrograde ejaculation for testing, we give at times the sympathomimetic drugs for 2 weeks, and normally I will cover this as I go ahead. Now, if the semen volume is normal, this is the importance as the role of fructose has gone away. If the testicular long axis is more than 4 centimeter, 4.6, and FSH is less than equal to 7.6 milli international unit per ml, then it is almost 96% cases, it is suggestive of obstruction. And if it is less than 4.6 and FSH is more than 7.6 ml, then it is almost 90% spermatogenic dysfunction. Right? So, transrectal ultrasound, if the dilated seminal vesicle, that is anteroposterior diameter, is more than 1.5 centimeter and a midline cyst is palpable, then it is operable, and ejaculatory duct obstruction is one of the cause. In this case, one can plan for transurethral resection of ejaculatory duct. If it is normal, in that case, there is most probably it is a non-operable fibrous block. In those cases, surgery will not be possible. So one has to go for percutaneous epididymal sperm aspiration followed by ICSI. If the results are equivocal, then there is some role of diagnostic biopsy, but in today's scenario, there is hardly any role. And even if the biopsy has to be done, then in that case, the further management should also be available in the same place. Just by diagnostic biopsy doesn't help. It has to be combined with the therapeutic aspect. And if it is normal in all, it is an obstructive azoospermia. And then we have to plan for the surgery, VA or VPA or HC. If few sperms are seen in biopsy, that means it is a testicular failure with focal spermatogenesis. So they say HC. And if there are no, that means testicular failure without focal spermatogenesis. One has to go for donor insemination or adoption. Now, diagnostic testicular biopsy should not routinely be performed to differentiate between obstructive azoospermia and non-obstructive azoospermia, as I've already highlighted. Transrectal ultrasound in a given is suggestive of ejaculatory duct obstruction, that is acidic, azoospermic, volume less with normal serum testosterone and palpable VAS difference. Renal ultrasonography for patients with basal agenesis to evaluate for renal abnormalities. Genetic assessment, karyotyping and Y chromosome. When in case of azoospermia or severe oligospermia, that is less than 5 millions per ml, with elevated FSH or testicular atrophy, or a presumed diagnosis of impaired sperm production as a cause of azoospermia. Non-obstructive azoospermia or severe oligospermia offer Y chromosome microdeletion followed by genetics counseling. Genetic counseling because Y chromosome microdeletion will be transmitted to the male children by HC. In this, the azoospermic factor A, B, and C is seen, and the A and B, there won't be sperm available. If it is azoospermic C, one can try for, there is a possibility of getting sperm retrieval. For men who harbor a CFTR mutation, genetic evaluation of the female partner should be recommended. Azoospermic men, mostly there is a sex chromosomal abnormalities. Oligospermic men, it is mostly autosomal anomalies. Affected offspring, in case of CFTR mutation, 25% if both partners are carriers. It is 50% if mutation in both alleles in the male patient, the female partner as a carrier. Now, coming to the sperm abnormality, medical management. There is a certain specific therapy, empiric therapy, and recent advances or new evidences. Now, the amplitude receptor manipulation. This is basically, even with a certain amount of LHFH, some people are able to impregnate and others it is not. And the reason is exactly not known. They say that the pain is able to sense, differentiate. So it is the receptors, how they are responding. So receptor unresponsiveness, which there can be damage on the receptor, block, polymorphism, or apoptosis. So now certain just medical guideline, if the low normal FSH, which is taken as a 4 to 7, so less than 4, one can try this clomiphene or HMG. Low normal LH, again around less than 4 to 8 is the range, so less than 4, HCG. Low normal FSH and LH, HMG plus anti-estrogen in the form of tamoxifen. High normal FSH LH, more than 8, it is dysgenetic testis. So medical treatment will be futile. So this is the importance of the endocrinal evolution. In the first basic endocrinal evolution in the severely oligospermic and all, only FSH and testosterone is done. But as we progress from the line of evaluation, these are the LH and prolactin and all are included. Now, another testosterone to estradiol ratio is important. If it is less than 10, then one can try aromatase inhibitor anastrozole 1 milligram alternate day. This is one of the recent things. Previously, we were taught that it's around 70 to 90 days spermatogenesis, but the latest finding is that 50 days of spermatogenesis and around 14 days of spermiogenesis, where there is a compaction in the epididymis and finally in the ejaculation. So it comes to 60 days. The importance of this is that, so if we have to give any empiric therapy and to repeat the check, around 1 to 2 months is the time. So 60 days, the importance of 60 days is because of that. Now, hypogonadotrophic hypogonadism, if it is secondary to hyperprolactinemia, this can be because of this pituitary adenoma, in that case surgery. Otherwise, dopamine receptor agonist has been tried, abergolin, bromocriptine and all. Then if it is hypothalamic origin, in that case, gonadotrophin releasing hormone in the pulsatile form, subcutaneous or IV. If it is pituitary origin, HCG. If azoospermia persists after 6 to 9 months of treatment, menopausal gonadotrophin or recombinant FSH has been tried. Now, varicocele, it is one of the commonest treatable surgical cause of male infertility. So there are a lot of controversies when to operate, when not to operate. Varicocele rupture improved outcomes following ART, even if semen parameters did not improve. So in today's scenario of ART, even in an azoospermia, if it is required, one has to do, but clinicians should not recommend varicocelectomy for men with subclinical varicocele or normal semen analysis. This is important. Clinical should not recommend varicocelectomy for men with subclinical varicocele or normal semen analysis. For men with a clinical varicocele and non-obstructive azoospermia, couples should be informed of the absence of definitive evidence supporting varicocele repair prior to ERT. And if FEA and varicocelectomy has to be done, both should not be done in the same sitting because there is a high chances of testicular artery injury. And varicocelectomy among the group, microsurgical subinguinal varicocelectomy is the gold standard with a very minimal complication rate. Hydrocele formation is around 0.4%, and recurrence is also around 4%. So these are the things. Now, non-surgical sperm retrieval. When man is unable to produce an antegrade ejaculate, that is an ejaculation, there are three situations possible. One is situational anejaculation. In that case, you can try for a vibrator stimulation in the clinic setting, and it usually works. And I have worked in the spinal cord injury center in Pune. So the vibrators are very costly. At times it is not available. So even the simple massagers can act as a vibrator. So it can be used. And electroejaculation is just for theoretical purposes. It requires proper anesthesia, and it's a very costly equipment, not easily available. Second situation is anorgasmic anejaculation. These people have a nocturnal emission but are unable to reach orgasm in a waking state by masturbation or intercourse. These are mostly psychological, but in these cases, vibrator stimulation works. Orgasmic anejaculation. There are three things. Failure of emission. That is due to the damage to the sympathetic nerves because of spinal cord injury, diabetes mellitus, lumbar sympathectomy. In this case, vibrator stimulation or electroejaculation can work. If it is because of anatomical block due to infections, that is genitourinary tuberculosis, the commonest. In that case, nothing will work. So surgical retrieval is the answer. If there is a retrograde ejaculation because of autonomic diabetic nephropathy, sympathomimetics are tried. Pseudoephedrine, Campbell's mentions pseudoephedrine 125 milligram about a day prior and 120 milligram 4 times a day prior, and around 120 milligram PD on the day of the coitus. And anticholinetics, imipramine, usually we give 50 milligram HS. Retrograde ejaculation due to bladder neck damage by surgery like QRP or TRP or trauma, sperm retrieval from bladder after alkalinizing the urine. Idiopathic infertility is that, as I said, almost 33% people are there. Oxidative stress has been accounted in 80% of men, and their oral antioxidant has been tried empirically. And as I said, that 60 days is the limit. If you can try, you must try. Use of ACRM, that is clomiphene, has a limited benefits related to the results of ERT. Now, surgical sperm retrieval in obstructive azoospermia, where reconstruction not possible, that is either congenital bilateral basal aplasia or iatrogenic epididymal damage during hydrocelectomy, past damage during hernioplasty. This is a mesh reaction, and bilateral hernioplasty are being done, and to the past damage or infection, and obstructive azoospermia with failed reconstruction. And certain couple preservance, because it will take almost 1 year for the results of the VA or VVA to become successful. And non-obstructive azoospermia, the Sertoli cell-only syndrome is there in 50% of the cases, and maturation arrest 20% of cases. But there are focal spermatogenesis in 50% and 20% of maturation arrest. And situational anejaculation in the failed vibrator therapy. And if there is a total astheno or necrozoospermia. So these are the things. Microsurgical epididymal sperm aspiration. It has a better motility, a low complication rate, higher retrieval rate, but it is not suitable for non-obstructive azoospermia, and anesthesia is required. Open fine needle aspiration using 26 gauge needles are being done. It is simple, no anesthesia is required. The percutaneous epididymal sperm aspiration, 26 gauge needle is used, simple technique, local anesthesia, better motility, complication more, have a lower retrieval rate, not for non-obstructive azoospermia. And testicular sperm aspiration, 22 gauge needle is for obstructive azoospermia. It is simple, local anesthesia can be done. Complications are, however, more. Poor results in non-obstructive azoospermia, and retrieval rate is low. Finally, the TESE, which is the mainstay. It is best for non-obstructive azoospermia, low complication rate. And these days, it is micro-TESEs are being done. Needle aspiration biopsy, this I thought it's a practical thing. So I just mentioned it slightly that 18 gauge scalpel needle is used, which is the green needle introduced through the clinical. Suction is applied using 10 ml syringe. Out in motion thrice with the tubing is clamped. Needle withdrawn slowly. As the needle emerges, a strand of tissues comes out. It can be microforces pulled out. And this gives more sperm than tessa. Now, The sperm from non-obstructive azoospermia are often limited in number and don't survive thawing. Preferably fresh sperm retrieved on the day of oocyte retrieval is for ICSI. Testicular sperms have a lower DNA fragmentation compared to the ejaculated sperm. Microtasis sperm retrieval is almost 52% versus the conventional test. PSA has replaced open procedures, open only in rare cases of vessel aplasia where there is a very little epididymal fragment. This is one I had one short note I had seen. That's why I thought I will just cover it. Post-coital test, it has only for the exams. It is called Sim-Sewner test. It assesses the sperm mucus interaction. It has got not much of practical importance. It analyzes the favorable mucus characteristics for sperm penetration. It gauges the number and motility of the observed sperm. It's mainly for the idiopathic or unexplained infertility or hyperviscosity. 1 to 2 days prior to ovulation, the viable motile sperm suggests a normal sperm mucus interaction. If no sperm seen in post-coital test, recommend IUI. Notorious for lack of standardization and Sir?
Yeah, Dr. Nandi, please carry on. There is somebody who is not muted. Please carry on.
So I am on towards the end of my thing. A lot of recent advances are in future directions. This metabiomics has been used to assess the oxidative stress, this reactive oxygen species, and its influence on spermatogenesis, embryo vitality, and ERT outcomes. Dr. Vasan is working greatly on this, and I had a opportunity or good luck to interact with him in his lab. So metabiomics has been used to assess this. And then metabiomics is a study of cellular metabolic products and represents downstream effects of gene expression. And there is a paradigm shift from semen analysis to genomics, proteomics, and metabiomics based novel diagnostic protein biomarkers for male infertility. And the future diagnosis and management of male infertility are moving towards fusion of andrology with artificial intelligence using intensive machine learning despite their ethical limitations. Thank you.
Thank you, Dr. Bhashan. Dr. Misra, just I have something to say.
Yeah, please go ahead.
The fact is Dr. Bhashan available? I don't think he is logged in.
He has not joined. I believe he'll join in. But the next speaker is Super Tiwari.
From him also. But few things I would like to put forward, because this is an educational session. Well, few things what has been told, this is an observation from my side, quick observation before you go to the next session.
Right.
Well, yeah, Dr. Bisal Jalan had mentioned about the pampinifer plexus, 9 veins, conferencing to become the 2 veins in the inguinal region. And 1 vein enters into the abdomen through the deep ring. So let's not be very rigid about it. Many times we'll find more than 1 vein, 2 veins in between the artery comes. At one point of time, laparoscopic varicocelectomy was quite in vogue since the microsurgical varicocelectomy took over. So at that time, we have to be careful. The age-old Palamo's retroperitoneal approach. Then we had this laparoscopic. Now in the vogue, as has been rightly pointed out by Dr. Nandi, Colonel Nandi, that it is microsurgical varicocectomy is the standard of treatment for varicocele. Now, the second thing which has been told about this semen fluid analysis. Well, fructose is definitely of paramount importance in the initial evaluation of the semen. We cannot ignore the importance of semen, that we all know that there is a qualitative and quantitative. We are not very concerned about the quantitative, but qualitative has a lot of role to play in the semen analysis. Any standard laboratory, they always report on the fructose presence or absence. If the volume is less than 5 ml, it is not possible to do a Seri-1 test. And when the volume is 0.5 ml, don't go by one report. One has to wait for more than 2 reports to ascertain the volume is less than 0.5 ml.
Yeah, that's what I said, sir. Basically, it's important. As an old timer, we always follow that. But importance is gradually coming down because of this difficulty, and because the volume is very less. And this modified Selivanovs becomes very difficult. That is
what I was trying to drive in.
Sir.
You have very correctly said. See, we cannot dispense. One more point I would like to also mention for the knowledge of the students. We should not think of advising about the adoption or a donor insemination just based on the fructose at no point of time. Just because Haas is not palpable and the fructose is negative, we should not go ahead with the advice to go for a DI or artificial insemination. That is what I would like, DI or adoption, that is rather I would like to say.
Yeah.
Beautifully mentions about the varicocele. It is a classical teaching all along. Now everybody knows the WHO in the 6th manual has already modified the parameters. We should always refer that as a standard. And as you got the semen parameters, what has been told classically to the student, that if there is a space pattern in the semen analysis in more than one occasion, then one should think of correcting a varicocele. It is a very debatable area. Varicocelectomy is a very debatable area. And finally, I would like to say that as andrology practitioner, always will try to give a child from the natural father rather than by the artificial insemination, because gynecologists have taken over. You know, they do it rampantly. All the artificial reproduction technology are rampant. They do not give importance to evaluation of a male. As andrologists, we always should give importance to the male evaluation till we find that there is no spermatogenesis at all. These are the thing I wanted to drive in to all the students. Thank you, Dr. Misra.
Yeah, thank you, Dr. Hota, for your remarks. We'll move ahead with the next presentation, which is on erectile dysfunction.
So
and
Dr. Vasan
premature
will join within
ejaculation.
10 minutes, sir.
Oh, that's
Dr.
nice. That's
Yeah,
nice.
Dr. Vasan will join within 10 minutes.
Okay,
Yeah.
Papa.
So I'll request Dr. Tiwari, Asutosh Tiwari, to introduce himself shortly and go ahead with his presentation. His screen is already has already shared his screen. Yes,
Am I
Dr.
audible?
Tiwari.
Am I audible?
Yes, you are. Yes, you are audible.
A very pleasant morning to all the individuals present over here. I'll be presenting on erectile dysfunction. I am Dr. Ashutosh Kumar Tiwari, PDT Urology from IPGMR, Kolkata.
Please unmute your camera also, video. Dr. Tiwari, please unmute your video.
Oh, yes, I'm trying to do that.
Yeah.
So is it visible?
Yeah, it's visible. It's visible. Please go ahead.
Okay, coming on to the introduction. Erectile dysfunction had traditionally been considered a psychogenic disease. However, evidence is accumulating that it may be an early manifestation of systemic atherosclerosis, coronary artery disease, and peripheral vascular disease. Although erectile dysfunction is a benign disorder, it may affect physical, psychosocial health, and may have a significant impact on the quality of life of sufferers and their partners. Slide is not moving.
I believe you use the on-screen tab rather than physical tab.
Slides visible.
Yeah, continue.
Okay, sir. Erection is a neurovascular tisular phenomenon under hormonal control. It includes arterial dilatation, trabecular smooth muscle relaxation, and activation of the corporeal veno-occlusive mechanism. As far as definition is concerned, it refers to persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. As far as epidemiology is concerned, prevalence varies according to various studies. According to MMAS, it is 52% in men aged 40 to 70 years. According to Coleman study, it is 19.2%. And according to National Health and Social Life Survey, it is around 31%. Incidence also varies. It is around 26 per 1,000 male annually, according to MMAS study, and 19.2 according to the Dutch study. Risk factors. All risk factors of cardiovascular diseases are also risk factors for erectile dysfunction, which also include lack of exercise, obesity, smoking, hypercholesterolemia, and metabolic syndrome. Coming on the urological aspect, radical prostatectomy and post-radiotherapy are the important risk factors. Role of nitric oxide in cyclic GMP. When nitric oxide is released from the endothelium, cyclic GMP is formed, which in turn leads to lowering of the intercellular calcium, penile smooth muscle relaxation, and increased blood flow, resulting in erection. When phosphodiester 5 terminates, NO and cyclic GMP signaling pathway decreases, and this results in flaccidity. Pathophysiology. Endothelial dysfunction is a key event in the pathophysiology. The endothelium regulates vascular tone, coagulation, and inflammation throughout the vascular tree, primarily via production of nitric oxide. Endothelial nitric oxide possesses anti-atherogenic, antithrombotic, and anti-inflammatory properties and promote vasodilatation of vascular smooth muscle. Coming to etiology, it can be vasculogenic, it can be neurogenic, anatomical or structural. Apart from that, it can be hormonal, drug-induced, psychogenic, or even traumatic. Now, coming on to the diagnostic evaluation, the basic work consists of sexual history, which must include previous and current sexual status, a validated questionnaire in the form of IIAF or SHIM, symptoms of possible hypogonadism, and LUTs must be evaluated, including the IPSS score. This is followed by physical examination, which should focus on genitourinary, endocrine, vascular, and neurological systems. Now, coming on to the basic workup when a patient presents with ED. When a patient presents with self-reported ED, then medical and psychosexual history must be taken, and validated instruments like IIEF may be used in order to identify other sexual problems apart from ED, identify the common causes of erectile dysfunction, identify reversible risk factors for ED, and assess the psychosocial status. Once this has been done, focused physical examination is of paramount importance, and it takes into account the penile deformities, the prostatic disease, signs of hypogonadism, and the cardiovascular or neurological status. This is followed by laboratory tests in the form of glucose and lipid profile, along with total testosterone levels. There are certain specific diagnostic tests for evaluation of erectile dysfunction, which include nocturnal penile tumescence rigidity using RigiScan, vascular studies in the form of intracavernous vasoactive drug injections, penile dynamic duplex ultrasonography, penile dynamic infusion cavernosometry and cavernoscopy, internal pudendal arteriography, specialized Andrological studies. Coming on to nocturnal penile tumescence and rigidity test, it should be done at least on 2 nights. A functional erectile mechanism is indicated by an erectile event of at least 60% rigidity recorded on the tip of the penis that lasts for at least 10 minutes. Intracavernous injection test, it gives fair information about the vascular status. A positive test is a rigid erectile response that appears within 10 minutes after intracavernous injection and lasts for 30 minutes. This response indicates a functional but not necessarily normal erection, and the erection may coexist with arterial insufficiency or veno-occlusive dysfunction. A positive test shows that a patient will respond to the intracavernous injection program. Duplex ultrasonography of the penis. Normal values include a peak systolic velocity more than 30 centimeters per second, and diastolic velocity less than 3 centimeters per second, and a recessive index of more than 0.8. Arteriography and dynamic infusion cavernosometry and cavernosography. It is reserved for patients being considered for vascular reconstructive surgery. Coming on to the psychiatric assessment in younger patients, especially those who are younger than 40 years with long-term primary erectile dysfunction, psychiatric assessment may be helpful before any organic assessment is carried out. Now, coming on to the EAU recommendations. EAU recommends taking a comprehensive medical and sexual history in every patient presenting with erectile dysfunction, and it is a strong recommendation. This has to be followed by a validated questionnaire in the form of IIEF, and it also emphasizes on focused physical examination in the initial assessment. This has to be followed by routine laboratory investigations in the form of glucose, lipid profile, and total testosterone. Specific diagnostic tests may be done in those patients in whom it is actually indicated. Now, coming on to treatment, the primary objective is to determine its etiology and treat it when possible. Modification of modifiable or reversible risk factors either before or at the same time as specific therapies are used. As a rule, ED can be treated successfully with current treatment options, but cannot be cured. The only exceptions are psychogenic erectile dysfunction, post-traumatic arteriogenic ED in young patients, and secondary to hormonal causes, example, hypogonadism and hyperprolactinemia, which potentially can be cured with specific treatment. Coming on to the management algorithm for erectile dysfunction, a comprehensive medical and sexual history is is of paramount importance. And before any therapeutic suggestion, one should concentrate on the following things. One should identify and treat the curable causes of erectile dysfunction. Lifestyle changes must be incorporated in order to modify the modifiable risk factors and provide education and counseling. After this has been done, one can go for the various therapies that are available, starting with oral therapy with phosphodiesterase 5 inhibitors, intracavernosal injections, topical or intraurethral alprostadil, vacuum devices, and in case of vasculogenic ED, limited software therapy can also be given. After this has been given, we have to assess the response of the treatment. In the form of treatment, patient perceived treatment invasiveness, improvement of erectile function, related side effects, associated satisfaction. If the response is inadequate, then we need to self introspect, and we need to assess the adequacy of the use of the treatment options, provide new instructions and counseling, retrial treatment associated satisfaction, consider treatment alternatives or combined therapies. If still the outcome is inadequate, then one may plan for penile prosthesis. Lifestyle changes and risk factor modification. It must precede or accompany any pharmacological treatment. Besides improving erectile function, lifestyle changes may also benefit overall cardiovascular and metabolic health, with recent studies supporting the potential of lifestyle intervention to benefit both ED and overall health. Coming on to the oral pharmacotherapy, phosphodiesterase 5 hydrolyzes cyclic GMP in the cavernosal tissue. Inhibition of phosphodiesterase 5 results in smooth muscle relaxation with increased arterial blood flow, leading to compression of the subtonical venous plexus and in turn leading to penile erection. They are not initiators of erection and require sexual stimulation to facilitate an erection in the form of audiovisual or tactile stimulation. Sildenafil. It was launched in 1998 and was the first phosphodiesterase 5 inhibitor available in market. Its action starts within 60 minutes of administration. Its efficacy is reduced after a heavy meal due to prolonged absorption. It is available in the doses of 25, 50, and 100 milligrams. The recommended starting dose is usually 50 milligrams and should be adapted according to the patient's response and side effects. Tadalafil. Its action starts within 30 minutes after administration with peak efficacy in about 2 hours. Efficacy is maintained for up to 36 hours and is not affected by food, unlike the sildenafil. 10 and 20 milligram doses have been approved for on-demand treatment of ED. The recommended starting dose is usually 10 milligram and should be adapted according to the patient's response and side effects. Common adverse effects of phosphodiesterase 5 inhibitors include headache, flushing, dyspepsia, nasal congestion, dizziness, abnormal vision, back pain, and myalgia. Headache is a side effect that is common to all the phosphodiesterase 5 inhibitors, whereas backache and myalgia are specific for tadalafil. Now, safety concerns regarding phosphodiesterase 5 inhibitors. As far as cardiovascular safety is concerned, a number of trials have been conducted and they clearly show there is no increase in the incidence of MI in patients receiving phosphodiesterase 5 inhibitors. Chronic or on-demand use is well tolerated with a similar safety profile. Nitrates are absolutely contraindicated with phosphodiesterase 5 inhibitors. All phosphodiesterase 5 inhibitors show some interaction with alpha blockers, which may result in orthostatic hypotension. All these interactions must be kept into mind before prescribing phosphodiesterase 5 inhibitors. Now, management of non-responders to phosphodiesterase 5 inhibitors. The reasons could be incorrect drug use, lack of efficacy of the drug. Therefore, one should always check that the patient has been using a licensed medication, check that the medication has been properly prescribed and correctly used. Now, management of ED after radical prostatectomy. Phosphodiesterase 5 inhibitors are the first line oral pharmacotherapy for such patients. The response rate of phosphodiesterase 5 inhibitors in different trials has ranged from 35% to 75% and 0% to 15% in patients who underwent nerve-sparing and non-nerve-sparing radical prostatectomy respectively. In case of post-traumatic arteriogenic erectile dysfunction in young patients, surgical penile revascularization has a 60 to 70% long-term success rate. Corporeal veno-occlusive dysfunction is a contraindication to revascularization and must be excluded by DICC. Now, choice or preference between the different phosphodiesterase 5 inhibitors. There is no comparative study comparing the efficacy of one over the other. So the choice of drug will depend on the frequency of intercourse and the patient's personal experience. Now, head-to-head comparison between on-demand versus chronic use of phosphodiesterase 5 inhibitors. Again, various studies have shown that daily dosing is well tolerated and significantly improves erectile function. Coming on to vacuum erection devices, it provides passive engorgement of corpora cavernosa together with constrictor ring placed at the base of the penis to restore blood within the cavernosum. Efficacy in terms of erection satisfactory for intercourse is as high as 90%, regardless of the cause of erectile dysfunction, and satisfaction rates range between 27% and 94%. Complications. The minor complications include pain, inability to ejaculate, fatigue, bruising, and numbness, which occurs in less than 30% of the patients. Rarely skin necrosis may be encountered. Contraindications. The prime contraindications are bleeding disorders or on anticoagulant therapy. Vacuum ejaculatory devices may be the treatment of choice in well-informed older patients with infrequent sexual intercourse and comorbidity requiring non-invasive drug-free management of erectile dysfunction. Shockwave therapy, low-intensity extracorporeal shockwave therapy. It is a new entrant. It has been proposed as a novel treatment for erectile dysfunction, but current data are limited and clear recommendations cannot be given. Now coming on to second-line therapy, intracavernous injections. Patients not responding to oral drugs may be offered intracavernosal injections. Success rate is in the range of 85%. Alprostadil. It is the first drug approved for intracavernous treatment of erectile dysfunction. It is usually given as a monotherapy at a dose of 5 to 40 micrograms. Efficacy is more than 70% in general erectile dysfunction population, as well as in subgroups, which includes difficult cases like type 2 diabetes mellitus and coronary vascular diseases. Satisfaction rates of around 87 to 93.5% in patients and 86 to 90% in partners. Complications can be divided into local and systemic. Local complications include penile pain in 50% of the patient. It is self-limited. Apart from that, patient may also have prolonged erections and priapism and fibrosis. Systemic complications are uncommon. The most common is mild hypotension. Contraindications include hypersensitivity to alprostadil, men at high risk of priapism, bleeding disorders associated with high dropout rates, and limited compliance. Intraurethral alprostadil, a vascular interaction between the urethra and the corpora cavernosa, enables drug transfer between these structures. Efficacy rates are significantly lower than intracavernous pharmacotherapy. Coming on to combination therapy, a number of combination therapy have been tried. Papaverine plus fentolamine, which is also commonly known as Bimix, has been tried and has been shown to have a better efficacy as compared to monotherapy. Apart from that, papaverine plus fentolamine and alprostadil as trimix has also been tried. In India, fentolamine is not available, so as an alternative, chlorpromazine has also been used. And these combination therapy have been widely used with improved efficacy rates, although they have never been licensed for erectile dysfunction. The triple combination regimen has the highest efficacy rates. Third line therapy, penile prosthesis. It is basically indicated in non-responders of pharmacotherapy or who prefer a permanent solution to their problem. The two currently available classes of penile implants include inflatable devices, which can again be of two types, two-piece device or a three-piece device. The diagram on the left shows the two-piece device. The cylinder is incorporated into the corpora cavernosum, whereas the pump is put in the scrotum after creating a subatus pouch. On the right, there is a three-piece device. The two cylinders are inserted in the corpora cavernosum. There is a pump which is placed in the subatus pouch and a reservoir which is placed in the space of radius. Apart from that, we also have malleable devices which ensures a firm penis which may be manually placed in an erect or flaccid state. Various surgical approaches are there, penoscrotal and infrapubic. Efficacy and satisfaction rate. Satisfaction rates are in the range of 92 to 100% in patients and 91 to 95% in partners. The various complications include mechanical failure, which is seen in around less than 5% of the patient out of 5 years of follow-up, and infection, which is seen in 2 to 3% of the cases. The various penile prosthesis models available in market are semi-rigid prosthesis, the AMS tractor marketed by Boston Scientific and Genesis by Coloplast. Inflatable prosthesis, again 2-piece and 3-piece, 2-piece AMS Ambicor by Boston Scientific, 3-piece Titan by Coloplast, and AMS 700 by Boston Scientific. Thank you so much, sir.
Thank you, Ashutosh.
Thank you so much.
Am I audible?
Absolutely, sir.
Mishra sir, with your permission, just one small point. Ashutosh very nicely presented. there are just one or practical points. There is something called office sildenafil test, which we do very frequently these days. So that same that injection test, instead of injection, 100 milligram of sildenafil, right?
Yes,
but it requires a privacy, and you have to, patient should be in an empty stomach, and you have to provide him some stimulation and all. So that is required. And another practical thing for this test is that usually we use papaverine along with chlorpromazine, which you mentioned. That is the very easy and very scientific, and it has been proved that papaverine plus chlorpromazine. So papaverine at around 4 ml and chlorpromazine 0.15 ml. Papaverine comes in that 1 ml is around 30 mg, and this chlorpromazine is around 25 mg per ml, so 0.15. So then we take 0.1, 0.4, 0.6 accordingly. Gradually we give a test, but we should always be careful about the priapism thing. We should be ready to manage it. And lastly, this testosterone test, for the free testosterone, one should be very careful about this testosterone test, because most of the assays done in the laboratories are not correct, right? So that is one important thing. And one should never ask for this free testosterone, which are also been done by a lot of practitioners and all. Ideally, you should test this testosterone total, then sex hormone binding globulin and albumin, and then on the line on net you get the free testosterone level, right?
Absolutely, sir.
Thank you.
Thank you so much.
Ashutosh, will you be presenting on PE as well, no?
Yes, sir.
So go ahead, quickly.
I think Vasan sir has also joined.
Yeah, welcome, Vasan. Dr. Vasan has joined.
Yeah. Hello.
Yeah.
Oh, that's nice. So just in another 10 minutes, you'll be listening you.
Okay.
So Ashutosh, will you go ahead now?
Yes, sir.
Please, quickly.
I'll do that, sir.
Vasan sir, good morning.
Good morning. Hi.
We are all eagerly waiting for your presentation. And the
Oh,
students are also eager to see the practical
no
processes placement.
Sure. I'll do my best.
Thank you, sir.
Dr.
I have-
Vasan, on behalf of Zone, we are welcoming you and thank you very much for giving your valuable time
Sure,
for
sir.
the students.
And on a very short notice, very short notice, he gave his valuable
Inviting in a
time.
very short notice. We are really, really grateful to you.
No problem.
In future, we will have you in a bigger platform very soon.
Sure, sir. No problem.
Thank you. Thank you.
Is my slide visible?
Yeah, visible. Please make it full screen and go ahead. Please make it full screen, Ashutosh.
Yes, sir. Sure, sir.
In the right corner, yeah. Yeah, that's the. Not happening.
No, sir. I don't know.
By the time Ashutosh is getting ready, again for the students, this colored Doppler imaging are also not, one should be very skeptic about taking the readings, because the radiologists are routinely not trained for this studies, right? This is for the students at take home. This is being very misused, penile colored Doppler. Thank you.
I believe the andrologists themselves should do it in case they
Correct, sir.
want to do.
Whenever we have doubt, we usually go to the radiologist, read, and then along with him we try to see. But sir, left, right, and center, it is being misused.
That's true. So it's not, yeah, it has happened. Please go ahead.
Is it visible?
Yeah, it's visible. You are also audible. Please go ahead.
So coming on to the definition. Now, definition of PME. Premature ejaculation is a male sexual dysfunction characterized by perceived inability to control ejaculation that occurs sooner than desired or expected, either before or shortly after vaginal penetration, and causes emotional distress for patient and or sexual partner. Now, coming on to epidemiology, it is the most common sexual disorder in men younger than 40 years. Prevalence of PME is 30% in the age group of 18 to 29 years, 32% in the age group of 30 to 39 years, 28% in 40 to 49 years age group, and 55% in the age group of 50 years to 59 years. Prevalence rate is found to be 2.3% for lifelong PME, 3.9% for acquired PME, 8.5% for natural variable PME, and 5.1% for the subjective PME. The etiology of PME is largely unknown, but little data does suggest several underlying causes, including anxiety, penile hypersensitivity, and 5-HT receptor dysfunction. The pathophysiology of PME is poorly understood, but has been hypothesized to be due to hypersensitivity of 5-HT2C receptor, hypersensitivity of 5-HT1A, 1B receptors, hypersensitivity of glands, psychosocial and relational factors. Lifelong PME. It refers to PME that occurs at all or nearly all intercourses with all or nearly all women within 1 minute in majority of the cases, consistently present throughout the life, and inability to control ejaculations. Whereas acquired PME refers to rapid ejaculation occurring at some point in time, normal ejaculative function before the onset of acquired PME. Often the underlying cause is identifiable, accompanied with inability to control ejaculation. Now, coming on to the various diagnostic criteria, according to ISSM, that is International Society for Sexual Medicine, ejaculation that always or nearly always occurs before or within about 1 minute of vaginal penetration from the first sexual experience in case of lifelong PME, or clinically significant and bothersome reduction in latency time, often to about 3 minutes or less in case of acquired PME. Inability to delay ejaculation on all or nearly all vaginal penetrations, negative personal consequences such as distress, boredom, frustration, or avoidance of sexual intimacy. According to DSM-5 criteria, there are four categories. Persistent or recurrent ejaculation that occurs within 1 minute of vaginal penetration and before the patient wishes to ejaculate, occurs in more than 75% of sexual encounters and is present for at least 6 months. Causes clinically significant distress in the individual. It is not due to another mental disorder, severe relationship distress, substance abuse, or an organic disorder. Proposed PME syndromes. There are various proposed PME syndromes, including the variable PME and the subjective PME. Variable PME is characterized by inconsistent and irregular early ejaculations representing a normal variation in sexual performance, whereas subjective PME is characterized by subjective perception of consistent or inconsistent rapid ejaculation during intercourse, while ejaculation latency time is within the normal range or can even last longer. It should not be regarded as a symptom or manifestation of a true medical pathology. PME has been classified into lifelong PME, acquired PME, variable PME, and subjective PME. Depending upon the intravaginal ejaculatory latency time, it is less than 1 minute in case of lifelong PME. It is less than 3 minutes in case of acquired PME. It may be normal in cases of variable and subjective PME. Coming on to the diagnostic evaluation, history should be taken very meticulously, and it should classify PME into lifelong or acquired, and should also determine whether it is situational or consistent. PME assessment questionnaires are available like PEDT, that is premature ejaculation diagnostic tool, physical examination and investigations. Now, EAU recommendations. EAU clearly recommends to perform the diagnosis and classification of PME based on medical and sexual history, and which must incorporate the IELT. Then it also emphasizes on the physical examination in the initial assessment of premature ejaculation to identify the anatomic abnormalities. But it says routine laboratory or neurophysical tests are not mandatory. They should be directed by specific findings from history or physical examination. Now, management is in a very stepwise fashion. First, one has to treat the other conditions if present. For example, erectile dysfunction is many times associated with PME, so that has to be taken care of. Either it has to be treated prior to PME or concomitantly with PME. This is to be followed by psychological or behavioral strategies, and finally the pharmacotherapy. Now coming on to the EAU guidelines, clinical diagnosis of PME based on patient or partner history, which must include time to ejaculation, that is IELT, perceived degree of ejaculatory control, degree of bother or stress, onset and duration of PME, psychosocial and relationships issues, medical history, physical examination. This is to be followed by treatment of premature ejaculation, which can be in the form of counseling and education, discussion of treatment options, and if PME is secondary to ED, treat ED first or concomitantly. Pharmacotherapy as first-line treatment option in lifelong PME, and the drugs commonly used are dapagliflozin, which can be as on-demand use, or off-label treatments which include chronic daily use of antidepressants like SSRIs or clomipramine. Behavioral therapy, primarily the start-stop technique or the squeeze technique is commonly used. Then the various pharmacotherapy for premature ejaculation. Daily and on-demand drugs are available. Drugs for daily intake include paroxetine, sertraline, citalopram, fluoxetine, escitalopram. Whereas for on-demand intake, dapagliflozin is a preferred drug which is started at a dose of 60 milligram 1 to 2 hours before the planned sexual intercourse. Other drugs include clomipramine and the local anesthetics. Now coming on to the prognosis, majority of men can be treated successfully with squeeze pause technique. Squeeze pause technique combined with SSRI can improve or cure most cases of PME. If the couple is committed, no problem. Reported relapse rate is in the range of 20 to 50%. Several males may need to
Can I
check
request everybody to
of behavioral therapy. SSRI might need to use lifelong medication. No known direct morbidity or mortality from PME, but self-esteem may be affected and may lead to. Thank you so much for your patient listening.
Thank you, Ashutosh. Without spoiling more time, we'll quickly move on to the presentation by Dr. Bhasin. As you all know, Dr. Bhasin is a renowned andrologist of this country. He is based in Bangalore and practices in Bangalore. There's a lot of publications in andrology also. He did his MBBS from St. John's Medical College in Bangalore. He did his MS from Madras Medical College. He did his DNB in urology from Apollo Hospital, Chennai. He has done a fellowship in andrology and urodynamics from Singapore. With this short introduction, I welcome Dr. Bhasin. Dr. Bhasin, please.
Yeah, 1 minute. Okay. You're able to see my slides?
Yeah, we are.
Yeah, just to give you, before I start the video, I think I'll just show you there are various prostheses and there are various things which are associated with prostheses. But I thought I'll just share a couple of things. There has been a lot of evolution of prostheses over a period of years, and we know that several types of prostheses have come. And we predominantly use malleable prostheses because of the cost consideration. And also we do use inflatable prostheses, and both the types of prostheses evolved. And this is the list of prostheses which are available. As you can see, malleable is a huge lot, where you have the SHA prostheses, Promedon, Zephyr, Silimed, HR. Now at this point in time, I think we in India get SHA, we get Promedon, we get Zephyr, and we also get what is called Rigicon, and we get AM.
Am I audible?
So all these are available. So just to give you a perspective that the choice of selecting which is something which each surgeon has to decide by his own experience. It's difficult to say. So the primary consideration is probably in a malleable prosthesis, the rigidity of the prosthesis and the bendability of the prosthesis, and the patient comfort and the glance fit. So these are the primary considerations for selecting the prosthesis. I don't want to get into the details in a 20-minute talk, so that is the challenge. And then you have these are called non-inflatable prosthesis. Essentially, the SHA prosthesis, as you all know, has a soft distal tip followed by a stiff segment and a soft zone. So these are some of the advantages and disadvantages of prosthesis. SHA prosthesis basically has a very soft pinoscrotal area, a pinopubic area rather, where the bendability of the prosthesis is achieved, but at the same time during a penetrative sexual activity, it doesn't give the adequate stiffness, so you probably need to support the penis, especially if the penile length is more than 9, external penile length is more than 9 centimeters. Then the penis becomes a little unstable. So this is a very important counseling factor when you this thing. And I'm just going to rush through these slides because I don't have so much of a time. And inflatable, of course, comes in two types of varieties. One is the 2-piece and the 3-piece. Obviously, 2-piece is not completely deflating. It is only 20% deflating, whereas an inflatable 3-piece would deflate to an extent of almost 85-90%. So 3-piece is the preferred prosthesis, and in that you have 3 varieties, which is the AMS 700 LGX. What is LG? Length and girth expansion. And the CX, which is a controlled expansion, and this is CXR, which is a controlled expansion which is restricted. So this again is because where people are expecting a length increase along with a girth, and only girth increase, maximum girth increase, and CXR is for narrow fibrous posterior or proximal corporal area where your placement is a little narrow because of the previous prosthetic surgery, or because of pyronies, or because of priapism. Then you select that kind of a prosthesis. So these are some of the this thing, and I will show you a couple of this. And so essentially, what is the innovation which has happened over a period of years? One is, of course, the furlough introducer tool, which allows us to place the inflatable prosthesis, because unlike a malleable prosthesis which you can push because of the rigidity of the prosthesis, an inflatable prosthesis is a soft prosthesis. So consequently, you require a furlough introducer which has a groove and a needle which you thread onto the prosthesis, and you push the prosthesis through the glands. And then you have lockout valves to prevent auto-inflation, kink-resistant tubing, expansile implant cylinders, easier to operate pumps, because you need to have the manual dexterity, not necessarily. Some people have less manual dexterity, so it should be a one-touch operation, and more durable implant components, antibiotic or hydrophilic coated prosthesis. So these are some of the infection, and these are the modifications of the technology, paraline, silicon, a lot of materials came into picture in all this. The approaches are pretty standard. You have the pinoscrotal approach, which is the most commonly used approach worldwide, and then you have the infrapubic and the subcoronal approach. And this is the pinoscrotal approach. A lot of people do a transverse incision at the pinoscrotal area. I do a vertical incision, as I will show you. I find it more convenient. Again, it's a personal choice. I think a lot of Indian surgeons also use a transverse incision, and a lot of people use a self-retaining retractor. I hardly use any retractor. Just now we finished a prosthetic surgery, which was done by my resident. So that's why I was a little late in joining. So that is very simply, he just did it with one assistant, and we don't have a self-retainer. So it all depends on how you are trained and what exactly you want to achieve. And of course, pinoscrotal advantage is the pump placement, especially if you're doing a inflatable prosthesis. Pump placement is very easy because you are near the scrotal area. Otherwise, if you're using an infrapubic, you have to make a separate incision. But then the placement of the reservoir is easy in a infrapubic incision. So there are, like I said, each incision has its advantages and disadvantages, but for a beginner I would suggest a pinoscrotal incision, because it's very easy to do, because in a infrapubic incision sometimes placement of the dilatation becomes a challenge because of the acute angle and the pubic bone being present there. So this is the retractors, if you want to use, which is the original Scott metal retractor, which has been used to mentor Wilson disposable retractor nowadays, which comes into very useful and handy. But again, these are sometimes you use a disposable set, sometimes you use a permanent set. So this is the original Scott's suprapubic approach, where you make a very small incision. This is something like a, deep gloving incision of the penis, where you make a very small incision at the base of the penis, penopubic area, and you just expose the bilateral corpora in that area, identify the neurovascular bundle, strip the corpora, and consequently it's a very minimalistic incision. There is no need to catheterize because of the fact that you are exposing in the infrapubic area, and then you have a direct vision. Like I said, because of the acute angle, sometimes dilatation is difficult, especially in a fibrotic penis, but a non-fibrotic penis it's very easy. So these are incisions which sometimes we use because of the condition of the patient, which also matters. And this is the subcoronal, all of us know, especially if it associated with the pyrenees and you want to excise the pyrenees plaque or incise the pyrenees plaque, or there is a significant curvature, or post-priapism where there is extensive fibrosis, and you have a better control of the corpora, because here you expose the whole corpora and you can dilate individual segment if there is a challenge in dilatation. So this is the basic, ethos of a prosthesis. I have rushed through these slides basically because of lack of time. Most importantly, you should know, one is to learn prosthetic surgery. I feel prosthetic surgery is a very simple surgery. It's an extremely simple surgery. If you follow precise steps, I do not change my prosthetic surgery, even the incision or any step. Though we do about 5 to 6 per month, I have never changed it, and I have never found the need to change it. But you should be aware of what not to do in a prosthetic surgery, and that is the most important thing. Like I said, in terms of patient outcome or outcome of the various surgical procedures, it's almost similar. The choice is basically in counseling, selecting the right patient for the prosthesis. Make sure you have counseled him. Don't select the wrong patient who's there is always going to be an expectation mismatch, and that is what we try to avoid, because it's a surgery which is difficult to contemplate. A lot of people think that they will get a natural erection. We do not create a natural erection, we create a mechanical erection, and consequently there is a disconnect between the penis and the brain, and that they need to understand. And many people, if they don't understand that, if they expect engorgement of the penis at the time of the arousal which normally happens, then there is going to be a huge challenge post-operatively. It can even lead to litigation. So consequently, my advice is you have to have a very good counseling team which explains. In fact, my counseling team is 3-layered, where we explain with a video, then we have a session for the partner or the relative, and third is we also show a patient who's had a prosthesis, or we connect him to a patient who's had a prosthesis, so that sometimes they are unable to ask certain questions and they are able to ask. And also we have a elaborate video consent procedure where we go through that. So it's not about doing prosthetic surgery, it's about understanding whom to do, what to explain, and when not to do, and what to expect as a complication. Like, I will just rush you through again. One more, I think. How do I close this? One minute. Are you still people seeing? Are you able to see?
We are able to see your slides.
Yeah, 1 minute, 1 minute. I just have to exit this recording. I'm struggling to exit. Okay. Now, why is it asking me to leave the meeting? To exit this recording, should I leave the meeting and show you another one?
I believe you have to unshare the screen and again share.
Because I thought I can close this presentation and move on to the next one, but it's asking me to leave the meeting. So I'll have to exit and enter back again.
Sir, re-enter, sir. Re-enter, sir. You re-enter, sir.
Okay.
So while Dr. Basil is re-entering, any comment from Dr. Nandi or Dr. Putta? Is Dr. Hota still there? Dr. Nandi.
Sir,
I am very much here, Dr. Mishra.
So while he's loading his slides, you can give your comment on your experience with penile implant surgeries. You are the first to perform in eastern part of India, if I remember.
sir, you are already there, sir. Uh, you must throw some light first, sir. We are your students only. So you must throw some light.
Yeah, sorry. This is a very weird thing.
Yeah.
I didn't know that I had to enter
Okay, you have
again.
come back.
Yeah, 1 second. I'll just play my. I just want to share with you some of the complications which can happen, and then I'll finally play the video. Just give me 5 minutes to say. Can you see this slide?
Sure. We're able to see your screen now, Dr. Basan.
Incidentally, I don't. I would like to admit that some of these complications are my own, and I'm not ashamed to say that you can get into complications in a prosthetic surgery. So one of the important things is intraoperative complications, which is the dilatation of the corpora, where you try to maintain outward direction to avoid crossover perforation, but you could have difficulty dilating fibrotic corpora, where we have used all sorts of instruments, Otis, Dilemma's insert, Rosa cavernotome, Uramex cavernotome, or even scissors, which I prefer. So this is wrong sizing, which is called undersizing, where you have undersized one side, and this is a typical complication, especially seen with.
Yeah, we're not able to see any picture. We're just seeing your.
You're not seeing it?
We're just seeing a page of
The screen only seen.
Screen is seen.
I will just go back.
Before sharing, probably minimize the screen. Yeah, now.
Yeah.
And now we are able to see.
Yeah. So this is called wrong sizing or undersizing, where you see the prosthesis one side protruding in the pinoglandular junction, and this will definitely perforate over a period of time. In fact, I expect perforation to happen in 6 months to 1 year. And so this is wrong sizing. This can be corrected with what is called as a glans hitch. Of course, it shortens the penis to a little extent, but that is a procedure which you can do without removing the prosthesis. If patient is very keen on maintaining length, you have to redo the other side and replace the prosthesis.
Reusable?
Hello?
Hey, go ahead.
Can
I request everybody to please mute their. There is a lot of background noise. Can everybody mute them?
You can reuse it. Reuse it করতে পারি আর এটা কিন্তু
Ranjan, Dr. Ranjan, please mute your.
Yes.
Please mute your mic.
Yeah.
Yeah, Dr. Basan, please go ahead.
Yeah. So one is if a patient is interested in maintaining the size, you will have to remove, and this of course you will have to tunnel into the glans because this has gone in the subglandular plane, and that is one thing. So this is called as a concord deformity, where you see the glans, which this is undersizing because both the cylinders have not entered the glans and the glans is floppy. So this is called as concord deformity, which you see. This is a typical, named after the Concorde plane which crashed and we no longer is in service, which was a service between transatlantic between France and New York. So this is a typical, again, there is, unless you want to shorten the glans, where you can put a glans hitch, where we bring the tunica and the glans together and tighten the glans over the tunica and retain the prosthesis, which will shorten the length by approximately 1 to 1.5 centimeter, or you have to replace the prosthesis retunnel. So this is called as concord deformity, where we do this. And what are the challenges? Whenever you wrong size, there is a risk of erosion and there is constant pain. And this is again wrong sizing. Again, these are minor defects, but these are very bothersome to the patient because he will not get this one. And then you have the perforation, where you can have a discal corporal perforation, which is small, you close with a close primarily. If it is a large, you have to use a graft, or during dilatation you can have a perforation. You always make sure that the dilators are in the crura. Check the heights of the dilators individually, both should match, and especially perineal. Make sure you are sterile and palpate the perineal because you could perforate even the perineal side. And earlier days we used to do MRI and all that to see where the perforation has happened, but I think it is a clinical decision. You can easily make out if you are perforated. And generally I used to use a Dacron graft to close these perforations. Nowadays I don't do anything. I place a shorter prosthesis and I hitch the prosthesis, usually a minor perforation, even unless it is a gross perforation where you are entering into the perineum totally, you don't need to. So we don't use this Dacron sock which you used to make earlier. And then there is a crossover perforation which is two implant in the same corpus. Then you have to redo and do an ipsilateral correction. And of course, how do you identify a perforation? When you ureterally irrigate, then you see fluid coming. I mean, when you use corporal irrigation, you see fluid coming in the urethra, then you know that there is. Earlier days we used to do cystoscopy. Nowadays we don't do all that because it's not necessary. And if it's a large perforation, it's always better to remove the implant and place it at another time, not to do the implant because the chances of infection are very high. And this is an S-shaped deformity because of oversizing, because you have oversized and it is in the corpora, but your length is more, so the penis bends. It is never straight. It is like an S-shaped deformity, and that causes a problem. And this is an inflatable prosthesis where there is a small herniation which is happening here. So that is again one of the challenges of extrusion. So that is, and this is an erosion which has happened of the prosthesis at the distal gland. This is a typical spot where it will erode. If the patient doesn't come back in time and there is a secondary infection, you can even have an erosion. Erosion immediate, you could probably look at, repairing it. You can buttress the radii if it is not eroded and you identify this imminent erosion. But if once it is eroded, once it is exposed to the outside skin, even for an hour, there is no question of salvage of these. Earlier people have attempted salvage, but it has been disastrous for the patient because it causes a lot of fibrosis. And the moment there is something like that, we remove. Of course, you could have cylinder faults, mechanical failure, loss of fluid due to breakage, bulging, aneurysmatic dilatation. Because after Paraline came into picture, all these have reduced. The cylinder bulging has reduced. This is an aneurysm of the cylinder. I have a fantastic collection. I could show you more and more because I used to operate in Singapore where we had several cases, and obviously when you do more number of cases, you have all these kind of problems. And you could repair the cylinder. Earlier days we used to repair this aneurysm of the cylinder instead of removing it. Nowadays, of course, we can get a new replacement, and that is not. This is the aneurysm of the cylinder. So how it happens. So this used to happen. So and then you can have component failure, breakage of cylinder, tubing, pump reservoir, all sorts of things can go wrong, and especially you can create an iatrogenic injury, especially when you're closing your cavernotomy due to retractor hooks. So you should be careful on this. This is a cylinder kinking. Basically because of wrong sizing. This is not a cylinder fault. This is because you have used the cylinder which is a little longer, and consequently when you create an erection, the cylinder is longer than the corpora and the shaft kinks as an S-shaped deformity. So these are various procedures I wanted to show you. Now I'll show you through the video. Maybe I'll have to exit again and come back. Let me just see if I can show you the video without exiting.
Mishra sir, your experience with inflatable processes, sir?
Well, I don't have any experience.
Just one second. Let me just get my
Already
video
saw.
first.
Even I have never done it, sir. Only Shah's processes.
Only SAR.
Sir.
So this is a case we did 2 days ago. I just did a workshop three days ago. I mean last weekend, Saturday, Sunday, in a fresh cadaver. That also we will show you some of the pictures. Where is my? Yeah. I don't know whether I have to exit here.
It's always easier once you exit and can re-enter.
Can you see this? No.
Not yet,
No,
sir.
not.
Okay. Okay, I'll have to exit then. Okay.
Yeah, that is always easier.
Okay.
I believe you can unshare and again share. That will be.
That is also one way, unshare and again share. These days, everything has become so technical,
Yeah.
but only you can enjoy it in the comfort of your home.
Yeah, that's a very. So, Doctor Hota, does he have any experience with inflatable prosthesis?
Yeah, no. Let's listen to Dr. Bhashan first. In fact, all the students are there along with us. So let's Dr. Bhashan finish.
While he's loading.
Then we can have a small interaction pertaining to our issue about the use of prosthesis.
Sure.
1 second. Can you see this?
Not yet. We are seeing the screen, but not the pictures. Not the video.
Are you able to see now?
No, not yet.
1 minute, I'm sharing.
Yeah, Dr. Bhashan, may I come in? Dr. Hota here.
Hi, sir. Hi. 1 minute,
How
sir. I'm
is
just
the
trying to
interaction?
just let me get the screen organized because this is a critical video. I don't know why it is not coming up. So
Yeah, there is possibly the support is not there on the screen when you play the video. I think
okay.
you can always describe whatever experience you had in the last workshop, which will be tips to the students.
No, I'll try to see this video. Why it should not come up? It will not come up, is it? I don't know what is. 1 minute. And just give me 1 minute.
Sir,
I think
you play the video, unshare the screen, play the video, minimize it, then share, and then probably.
yeah, that's what I have done. I've already done that. That is what 1 minute. I'll just do that one more time. Yeah, I've played the video.
Minimize it, pause it, minimize it, then share, and then.
Yeah, that's what I do normally. Uh, 1 minute, I'll move it to desktop. Just give me 1 minute. Because it's not showing any video file. I don't know why. Just give me 1 minute. Now, will you able to see?
Yeah, now we are able to see.
Okay. Okay, I'll just quickly run you through. This is my prosthetic surgery. Dr. Fahim and Dr. Ashish are with me at this point in time doing Rajiv Gandhi Fellowship in Andrology. So this is the scrub we give, which is a betadine scrub. This is a standard scrub. I'm just showing you step by step. Of course, this is malleable. I'll just show you inflatable afterwards. So consequently, and we don't use anything else other than betadine scrub. I've been very happy with it. I know a lot of people. So post painting, we wait for about 5 minutes, which is a standard protocol, which we use, and we scrub thoroughly. This is a 19-minute video, so I'm going to slightly hasten up the process where it is not necessary. And then we use the sterile drape, and then we bring out the penis through that small incision, which we make. So that is this is the part, and this is the instrument trolley
from 9 French to 13 French, which is dipped in a saline with vancomycin mixed with antibiotic vancomycin. We have 20Y3, which is also will be dipped in vancomycin, and for flushing we have 10cc syringe along with blades handle 11 and 22 number. And the other required instruments are forceps, scissors, and mosquito. That's it.
So that was Dr. Fahim, who just did another process just now. So he is upstairs. So what we do is we expose the urethra. We make, like I said, I make a vertical penoscrotal incision. I don't make a transverse incision. I don't use a self-retaining retractor, but I generally flush that area with antibiotic solution, which is my vancomycin solution. Quite generously, 1 gram of vancomycin is 500. So the moment I expose the urethra, mine is a very minimalistic incision, just a 1.5 centimeter incision. I don't go beyond that. The moment I don't use a catheter. I have never used a catheter unless there is a problem with the urethra. So we just expose the urethra and then identify the plane next to the urethra, which is the corpora. So as you can see, it's a very, very small, tiny incision. And we generally try to finish. So that is the corpora. So we identify the urethra. We don't do any extensive dissection. Yeah. So we create that shelf of the urethra. So we identify 4 stay sutures, put it in the corpora, and
change the retractor like that. And now you can see the shelf.
I'm going to hide this my discussion there. So that is the corpora. So we just expose the corpora. So I take 4 sutures, 2 medial towards the urethra and 2 lateral away from the urethra. That's your corpora. So you just take a bite, good bite with 2-0 Vicryl, and so that's the bite. This is very, very standard. I don't vary my surgery, not even one single bit. I have never found the need, fibrotic, non-fibrotic, I have never found the need to vary. So, and so the moment I do that, so we dissect that area. So that means you create a small area of, this is your, corpora which is very clean for you. And so as you can see, this is your urethra, and lateral to that is your corporal stitch. This is your urethra. So we have just exposed the corpora on the either side, one side, and this is the other side. Again, minimalistic discussion. Just use the peanut.
Should have been at least another 1 centimeter.
So again, expose the corpora. So the moment you expose the corpora, like I said, I don't use a self-retainer, nothing. I just make a incision in the corpora. So we create something like a shelf there by holding the suture and just make a nick there. The moment I make a nick, that is my nick, I just use an artery forceps to dilate that area because I want a subcunical plane. So that is the amount of bleeding you will have. Generally we use a no-touch technique. So once I create that subcunical plane, I just start dilating. And so that is your bone. And you can dilate very easily.
It is his control.
And so again, use the smallest dilator carefully because this is 7-8 Hagar's dilator. I just use a Hagar's dilator. And so this was done by Fahim. So again, we generally flush with vancomycin because it's a 1 gram solution. So that is the plane I want, just subcunically. I just compress the corpora. So stretch the penis. If you want, you can put a gland stitch and keep the penis stretched if you don't have, if you're not comfortable with a floppy penis, because some people are not comfortable with a floppy penis. So you just push it so that you get it into the mid glands. Never hold the skin directly, you hold it with a gauze piece so that the most common contamination is Streptococcus or Staphylococcus. So that is your this thing, and then serially dilate both sides. So as you can see, my incision is hardly 1.5 centimeter in the corpora, and then I dilate both sides, and then you use the sizer to measure. This is the sizer, which has this is not like a dilator, which has markings on both the sides. So actually, this incision is a little on the higher up side because Fahim was doing. He made an incision which is slightly higher up. It is not exactly penoscrotal. Basically, I would prefer to have more towards the penoscrotal area. This is fine if there is a de novo penis and there is no fibrosis, but if there is fibrosis, it's always better. That's why you see a discrepancy in when you push towards anteriorly, you will see the whole dilator going in, and when you push distally, you see a very few, very little of the, not the dilator, the sizer. So consequently, this is a mismatch because of the corporotomy, which is done more distally than proximally. So I would prefer to do that. This is the prosthesis we have used in this case, which is the promedon tube prosthesis. Of course, when there is a need to measure what size you put in. So you normally, there are various sizes in promedon. You get 9, 10, 11, 12, 13. So I think here we selected 11 size. Again, selection of the size is depending on the maximum dilator which goes in. So that if you know that you are putting in a 13 millimeter dilator, normally because this is a penis which stretches because of the dilator, I put 12 centimeter as the final cut. So again, after you measure the length, then you decide. We have a sterile scale. You use the length to cut the desired size. Always make sure that whenever you measure the
We lost the video. We lost you, Dr. Vasan.
Yeah, I think we can wait for a moment. Well, Dr. Nandi.
Yes, sir.
Hello. Yeah,
Yes,
Dr.
sir.
Nandi. What is your experience?
Regarding, sir?
This prosthesis? Jai Jagannath, Jagabandhu.
Jai Jagannath,
Yeah.
Jai Jagannath, sir.
Hi, Professor Hota.
Yeah.
So I have joined just now. I had some function. Anyway.
So, I saw you at the beginning. We are we are in the middle of Dr. Vasan's demonstration of a case of prosthesis. So he got disconnected. We are waiting for him. Well,
I
Dr.
think
Nandi,
he is using Shah's prosthesis.
No, that in fact that is the one he was using a semi-rigid one only.
But the
Well,
Shah's one, he's using Shah's.
well, Dr. Nandi.
Sir.
Yeah. Yeah, by the time we come back, because we are about to be 12, it is already 12 o'clock now almost.
Sure.
So, Dr. Misra, any other talk now?
I believe there is one talk by Dr.
Peronis.
Kumar on Peronis.
Yeah.
So
I think
should we go ahead with that?
12:10 is the timing. Now we are supposed to complete
Yeah.
by 12:10.
That's
But
true.
anyway, Dr. Nandi, you have a word with Dr. Vasan. What is the
Right,
problem?
sir.
Then we can,
Sir,
then we
sir.
can go ahead further.
Sure,
Yeah.
sure, sure.
He is joining, sir. Actually, he has disconnected from his network. He is joining, sir.
Okay.
At times, Sinan sir can give us a joke.
Hello. And,
Good
why
morning,
not I
sir.
ask some question to the student? How many students are there now in the screen? Hello.
There are about 20. There are about 20.
No. Those students who are on the screen, because
Around 20, sir.
Yeah.
hello, he is joined. Come on. Let him continue.
Can you see me?
Yeah, we can.
Yeah, so I'm just shifting back. I don't know where I missed. So this is after the sizing, you place the prosthesis. So you select the prosthesis and you place the prosthesis. I'll quickly take it through. So this is a very minimalistic incision. So we stretch the penis, place the posterior, proximal part, and then push the anterior part. So there is a little bit of maneuvering. This is more like carpentry job. So you need a clear direction. And you should never undersize just because the corpora is a little tight and you undersize, patient is going to be unhappy. So you need good exposure here. So and this prosthesis bends. So consequently, it is best. So you just have to maneuver the prosthesis inside. This is a little tricky step where the tendency is to make a big incision, but I never make a big incision. So like you said, the prosthesis has a spring-like action. So you just need to make sure that you use as minimalistic incision and enter the right plane. Once you are in the right plane, it just slips in. And of course, you need a good breakfast so that you just push it into the plane. So that is the key step. So which we all learn over a period of time. This is something which we learn. So like that, you just push it in. So I'm just showing it to you repeatedly, basically because this is a critical maneuver where people can create a false plane. So once you push it in, it just goes in, then your prosthesis is in. That is the way the prosthesis should go in. And then you use pressure both proximally and distally to slide the prosthesis in. So that sliding maneuver, as you can see, it just sits into the penis. So that's the slide which you need to do. You can see the prosthesis is near the glands. So, and sometimes the gland, I mean the foreskin is very tight, you do a circumcision at that point in time. So this is as you can see, it is in the mid glans. So this is a malleable prosthesis insertion, and like you said, I did a vertical penoscrotal incision. It's a very small incision, and this is a live surgery. So it's unedited video, so probably you will see a lot of muck around, but still it is a very minimalistic surgery. So so this is again, I'm just closing. So we just closed that incision. Like I said, the only defect is in this he made an incision which is a little higher, basically because if you put a gland stitch, then you stretch the penis. If you don't stretch the penis, you could make this mistake. Now I'll just show you one or two videos of inflatable. I hope I can get my desktop. One second.
Dr. Bharshan?
Yeah.
Yeah, because we are a bit running out of time. If you can make it as required, if you can present it quickly.
Okay, sir. I just wanted
students would like to know from you. Students will like to know from you by questions and answer.
Okay, then I'll stop here, sir. I can show this later. I can send it to you on WhatsApp.
You can always share the video in our group.
Yes, sir. I'll do that. Yeah. I'll do that, yeah. Sir. Okay. Okay.
In our regional group, if you can put it, I think it will be to the interest of everybody.
Sure, sir.
But let me start few quick questions.
Yes, sir.
First of all, merits and demerits of the midline incision right on the urethra.
On.
I mean, I'm very used to it. I find it very, very useful because I don't use a catheter. For me, the primary aim of this incision is to identify the urethra and separate the urethra. So I'm right on that urethra. And the moment I make an incision, I just enter straight into that plane. And since I don't use a catheter, I find it very, very useful. So I have no demerits with this incision. And it is a very bloodless plane. I don't have any crossover of blood vessels, nothing. You have to stick to that penoscrotal straight incision. So, and scarring, I've never had a problem of wound dehiscence or anything of that sort, and patient doesn't note the scarring post-op. And secondly, for me to do a redo, this incision is perfect because it has not disturbed the other planes. So I can go into this incision, and in case there is extensive fibrosis, I can always make a lateral incision and still expose the corpora, because I know into this incision the urethra will be bound. So I know if I make an incision lateral to this, then I'm very safe, because I will hit the, of course I will use in a very badly fibrotic case, I will always catheterize. So what I'm saying is, then I know that because of this previous incision there is fibrosis and the urethra is adherent, I just make a lateral incision. So for me there is no demerits.
Okay, second thing I think for the interest of the student also, for a pretty long time, you know, particularly in India and particularly in areas like Eastern Zone, we rarely use it inflatable because people are not very much willing, and counseling is a major part of the prosthetic surgery, as you know.
Sure, sir.
Some situations like patient has got a fibrosis on one side and the second side is compatible better. Would you also recommend a single side prosthesis also in
No,
situations like this?
inflatable, you can't put a single side, sir.
No, I'm talking about semi-rigid.
Semi-rigid, yes, sir. So occasionally, yes, this kind of situation happens where for some reason, let's say, let's put it this way. The classic example is one side prosthesis extrudes. Now, when it extrudes, we leave the patient after the removal of, we don't remove the other side prosthesis. For some reason, it has extruded. We leave the other side and the patient is comfortable. So we leave him alone with one prosthesis. We don't suggest that he has to go for another prosthesis. So it's the patient call. And many times you will be surprised that patient is happy because he doesn't want to go through the surgery again. Okay. So that is a classical situation. So if a patient is going to be happy with one prosthesis, as long as one side prosthesis is still mid-glans and it is not undersized and it is perfectly fitting. I think in a situation where you are unable to place the prosthesis primarily, even one side is a good enough for a person who has not had an erection at all. So I would go ahead and do that.
Yeah, Dr. Varshan, they're very nice. And finally, well, I have been emphasizing on the counseling part of it. How often you give a prosthesis without the consent of the wife? Do you take both into counseling or not?
Sir, in India, very few wives come for counseling. Though we request them, very few people bring. My experience is, at least in Bangalore, only 20% of wives are involved in the surgery. Many of the wives, we do not see them at all. So that is why we have instituted video consent. We have instituted patient, consent, in the sense that the patient experience, they are talk to another patient. So though I started off saying that wife consent is mandatory, if you insist on wife consent being mandatory, you will never be able to achieve it 100%. So that is the status in India.
The reason I am asking this question, because satisfaction rate of the partner also we have to take into consideration. We are putting
that.
Yeah.
But many a times, first of all, even post prosthetic surgery, partner satisfaction directly from the partner we don't get. We get from only the male partner saying that I'm happy. Generally, with a prosthetic surgery, if the sexual relationship either with his wife or with his fiancée or with his another partner, whatever it may be, if they are unhappy, they will sit on your neck. There is no way they are going to leave you, because they've got the surgery done for some particular purpose. Nobody, in my opinion, nobody goes through a prosthetic surgery unless there is a need for a sexual demand from the partner. Very rarely people get it done for their own personal pleasure. Most Indian men feel that they can masturbate and can live with masturbatory activity without a prosthetic surgery. It's only when you have a young wife, or you have a second wife, or you have a affair, or you have a wife who is more energetic than you, then you consider prosthetic surgery. This is my experience, at least in Bangalore.
No, thank you, Dr. Vasan. Anybody else would like to also put their viewpoint and let know from
Vasan, while dilating, if you have injured the urethra, what is your next step?
What, sir? Come again.
When you are dilating with the Hagar, if the urethra is perforated, what do you do at that point of time?
If the urethra gets perforated and the dilator comes out of the urethra, you abandon. Okay.
Pardon?
If the dilator comes out of the urethra, you abandon. If dilator doesn't come out of the urethra and you identify a perforation during irrigation of the corpora, that means you irrigate the corpora, there is a little bit of leak from the urethra, then if it is a distal perforation very near the glands, then you can still go ahead with the prosthesis. If it is a very small perforation, I don't search for the perforation. I decide the size of the perforation by the amount of irrigation fluid leaking out of the urethra. So I know if it is a major perforation, when I put the dilator, I can push the dilator through the urethra, then I abandon. If it is a very minor perforation, I just put a Vipro mesh. I just use a Vipro mesh, push it inside along with the prosthesis. I don't try to seal it or anything. I just push the mesh, put a catheter for 10 days. Don't remove the catheter. Patient will be fine.
Thank you,
Okay,
Dr.
thank
Vasan.
you.
I think a lot of things can be, asked. It is such an interesting area. I know that because of the time constraint, we are not able to know more.
Vasu sir, how you
But
decide the
anyway,
width?
One second,
The
sir.
width.
Hello?
How you decide?
Yeah.
Nandi, yeah,
Yeah.
please go ahead.
How you decide the width, sir?
Width.
Yeah.
Like I said, I push 2 dilators, Hagar's dilators.
Mhm.
Suppose you push, let's say 13 Hagar. I always over dilate. I dilate till 15, 16. Okay. So if you're pushing 15, 16 on one side and the other side only takes 13, 14. Obviously, you have to keep 2 sets of dilators so that ultimately you push both the dilators. So that is your diameter, essential diameter. So you go one size less. So if you are pushing 15, 16,
Acha,
then
Dr.
ideally
Nandi,
you
I
will be
think,
able to
can
fit
we,
in
can we
13,
request
14.
to complete this session now?
So, hello.
Yes, sir.
So I believe we'll stop here, Dr. Basim. We had nice
Sure.
interaction. What we'll do now is it's already time. Should we go ahead with the next speaker or we'll conclude here?
Thank you,
Hello.
Vasu sir.
Thank you.
Excellent presentation, sir.
Thank you.
So
And
Dr.
that was
Nandi?
unedited presentation. It is really very nice, sir.
Thank you.
So many practical things we have learned, sir.
Thank you.
Thank you, Wes, and everybody is so happy with the presentation and we look forward to listening you again.
Thank you, sir. Thank you very much.
Even with a slight wrong incision, you managed it.
Yeah. These are things which happen. I don't claim to be perfect. Of course, my student did it, but still, I was responsible. So I take
Sir, in
full
diabetic, what HB1AC, any cutoff limit you follow?
No, sir. There was an earlier cutoff limit that it should be less than 8 HbA1c. My only cutoff is on the day of surgery, I want it less than 200. I have done on 11 HbA1c. I have no problem in doing diabetic 11 HbA1c because I put them on post-op, whatever medication it is required. And my only cutoff is if the value is more than 200 on the day of surgery, I defer it for a day or two till I bring it down. I don't send a patient bank saying that get your HbA1c less than 8 and then I will operate. No.
And antibiotic, which one you follow post-op?
I always use Piptas 4.5, amikacin 500 milligram BD and Tiniba for 3 days. Piptas only for 24 hours. And after Piptas for 2 doses and amikacin 2 doses, we shift to oral. Because
This
next
is
day
clear.
morning, we operate today morning, tomorrow morning they are discharged.
So we'll stop here, Dr. Nandi. We'll go with Dr. Vikas Kumar presentation.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Thanks, sir. Thanks. I'll take leave. I have to go to the port. Thank you.
Okay.
Is Dr. Vikas
Yeah.
is here?
Yeah, yes, sir. I'm
So
just.
please.
So can you see my slides, sir?
No, not yet. Not yet.
No, sir.
No, please. We're seeing you on the screen, not the slides.
Okay, just.
To minimize them.
Ủa sao quý bà tôi gì? Cái này là mấy ngày cổ cái này tổ ra.
Now can you see? Now?
No, we are not able to see your screen.
No, sir.
You just unshare your screen and then again reshare. That may work. Yeah, now it's.
Just a minute.
But they said empty presentation.
Yeah.
So what I would suggest is you open the presentation, keep it minimized.
Now you can see.
Yeah,
this?
now we are able to see.
Okay, thank you.
Go full screen. and keep it short. It's already there is hardly
Yeah.
time.
So, good morning, everybody. So today, the last session, I'm going to present the Peyronie's disease surgical management. So it's already read. So I'm just going through the slides fast. So it's a gold. It's a gold standard for treating the Peyronie's disease. So before performing the surgery, disease should be stable, and that can be defined by onset of the Peyronie's disease should be 1 year before the surgery, and at least there is a stable deformity for 6 months. So indications for surgery are deformity that precludes the satisfactory sexual intercourse, pain may be there during intercourse, deformity causing the distress, and inadequate rigidity for sexual intercourse. So this is the normal picture. You can see the outer covering skins and dartos. Then it comes the buck fascia, then again the tunica and the corpora. So before going to this surgery, there is a hello. Yeah. So before performing the surgery, we should know the two things. One is the erection is adequate or not, with or without the help.
test হয়েছে
If it is
Kumar,
yes,
please mute your screen. Dr. Dhananjay Kumar, please mute your screen.
so if it is yes, we can do the duplex ultrasound and we can define the deformity. If it is less than 70 degrees and there is no hourglass or hinge effect, we can suggest, and patient is ready to accept the length loss, then we can suggest for the plication procedure. If he is not ready to accept the length loss, we can go for the plaque incision or partial excision with grafting. If there is complex or multiplanar curve deformity or deformity is more than 70 degrees, we can ask the patient for any, if he is ready to accept the erectile dysfunction, we can go for plaque incision and partial excision and grafting. If he is not ready to accept the erectile dysfunction, we can plan for the penile prosthesis. But if there is erectile dysfunction associated with PD, then we have to do the penile prosthesis, and we have to look for the functionality of the penile prosthesis, and according to that we have to deal the patient. So these are the things we have to explain the patients prior performing the surgeries, because there are some limitations of the surgeries like persistence or recurrence of the curvature, then reduction in the penile erect length, then diminished rigidity and decreased sexual sensation. So techniques, if you see, there are 3 techniques to correct the deformities. One is the tunica plication, tunica shortening procedure, that is tunica plication. Then is another is tunica lengthening procedure and penile prosthesis. So what is the things which determines your surgical procedures? One is the pre-op erection is hard or not, enough to perform the sex or not. Second is deformity, severity of the deformity. So if it is adequate erection and curvature is less than 70 degrees, you can go for the tunica plication. If it is more than 70 degrees and there is hourglass deformity, you can go for grafting. And if the erection is not sufficient, then you can go for the penile prosthesis. So tunica shortening procedure advantages are, it is short surgical time, good cosmetic outcomes, then minimal effect on the rigidity, and it's simple and safe surgeries. Disadvantages are, it is shortening the length of the penis and it cannot correct the hourglass or hinge effect. So one method is Nesbitt procedure. Here we are making the elliptical transverse incision over the maximum curvature, and we are doing a transverse plication of the tunica. Another is Henke-Miklich procedure, where we are making a vertical full incision over the maximum curvature on the tunica, and we are closing it in a transverse way. Third one is the dot procedure. Here actually we are taking the Lombard sutures, and that is around 0.5 to 1 centimeters away. in to out fashions, and we are, without incising the tunica, we are tightening it and seeing that whether it is erect and straight penis or not. So factors which are determining the length loss of penis is, one is direction, another is degree of curvature. Then another is tunica lengthening procedures, which includes plaque incision and grafting. Another is partial plaque excision and grafting. So indications are curvature more than 60 or 70 degrees, shaft narrowing, hinge effect, and there is extensive plaque calcifications. So most important patient we should know is the pre-op strong erection is there or not, and it is there, then we can deal with the great complex disease. We can treat with this plaque incision and excision technique. So disadvantages of this technique is it can lead to erectile dysfunctions. It is not good for the aged patients, and it can lead to corporeal veno-occlusive dysfunction. Large tunical defect and graft size is required, and ventral deformities have poor results. So plaque incisions, where you can make a modified H or double Y incisions in the maximum curvature areas. And another procedure is that you can make multiple incisions to decrease the chances of ED. So here are the things. I will show you the pictures. Yeah. So here you can see the hourglass deformity. So in that patients, what you have to do, you have to make a circumcoronal incision 1.5 to 2 centimeters proximal to the corona, and you have to deglove the penis. Then you have to take care of the neurovascular bundles in the buck fascia, and you have to lift it safely. Then you have to make a measurement of the hourglass deformity, and you can put the graft like totoplast graft we are using. So after taking the size, you have to fix the graft by radial sutures, and you are using the PDS sutures. And after putting the grafts, you can close the deformity, and things can be. So here you can see that totoplast graft we have put, and we have corrected the deformity, and it should be put in the erect positions, not in the flaccid positions. And graft length should be not very big. It should be less, not in the 10% of defect. And sutures we are using it the PDS suture 40, and maximum deformity we can correct with this incision or partial excision techniques. And this graft is put in the square or rectangular fashion so that it can correct the lateral and the dorsal curvature of the defect. And artificial erection is again done to see any residual curvature is there or not. Then after seeing that, you can close the buck fascia with the 40 chromic, and again you can position the skin with the 40 chromic, and dressing should be placed, gentle compression should be done. Another important thing is the post-operative management, like rehabilitation. It's very important. It reduces the post-operative erectile dysfunction, then it reduces the length loss and optimize the straight healing. So it should be started just after the surgeries, and massage and stretching therapy should be started 2 weeks after the surgery, and it should be done 5 minutes twice a day for 2 to 4 weeks. Then after 2 weeks, you can introduce and you have to use this PD5 inhibitors. Post-operative vasodilation. Then another, it reduces the
Ranjan, please. Yeah, Ranjan, am I audible? Ranjan.
So another thing, it reduces the gastric contraction and preserve the cavernosal tissues. And there is external penile traction devices which help in lengthening the penis, and it should be done for about 4 months. And it should be started in the first month with the 2.5 hours per day, around 4 to 5 days per week. and that should be continued so that length loss should be less. This is the traction device you can see. Penile prosthesis, I think already Vasan sir has discussed. So here we are using an inflatable penile prosthesis. Those who are having this peroneus disease with concurrent erectile dysfunctions, and this could be placed with this. Manual modeling is required by the penoscrotal approach, and it is very satisfying. Results are there, like 86 to 100%. And first we have to put the cylinders, and then we have to inflate it. And if there is any residual indentation or curve, we have to correct it with tunica incisions. So this is the thing, but the most common complaint is the length loss in this penile prosthesis. Thank you.
It's excellent preparation, Dr. Kumar. Well, then, Dr. Hutta, can you?
I'm coming. Is Dr. Rajendra Singh available?
I am there.
Yeah, please give your comment before we conclude the session, because you have joined late. We need to know from you the stalwart in andrology from our zone.
Dr. Vikas, please
thank you.
unshare.
Hello.
Dr. Vikas, please unshare.
Hello.
Okay, just a minute.
Yeah.
Dr. Vikas,
Professor Hota,
Yeah.
I just want to ask some questions to the student.
Yeah.
Hello. I just want to ask some questions to the students.
Yes, sir. Yes, sir.
Yeah, please go ahead. Please go ahead.
Please, all the students kindly identify, and whoever will answer, please answer. Otherwise,
Student कैसे identify करेगा?
Dr. Rajendra will himself answer it. Yeah.
So, students, good afternoon. You had a nice session. Our expert on prosthesis, Dr. Vasan, has dwelled nicely, and of course regarding the this thing, peroneal disease also, Vishal, he has spoken. So let me ask some questions connected to andrology.
Please make your video on. You have stopped your video.
Video on.
Rajendra, apna video on karo.
You can't see my video.
No, I can't see.
So, hello.
We are not able to see you. You please unmute your video, Rajendra.
No, I am having another computer because other one is having very low voice. But,
Okay, then go ahead. Go ahead. We are able to listen you.
Student, why there is agiospermia in Carter-Jenner syndrome? Just answer, explain why there is agiospermia. I repeat the question, why there is agiospermia in Carter-Jenner syndrome? Anybody?
No, you little elaborate on that. Immotile cilia syndrome.
No, let the student answer. Professor Hota is a pioneer in the andrology in the East Zone.
No, let me tell you. Just give some hints, because Carter-Jenner, the right away they may not be able to remember. So little hints. Yeah, somebody.
No, they are MC student. Hota, so they must know what is Carter-Jenner. Tell me the components of Carter-Jenner syndrome. As Professor Hota has asked me, there are around 30 students. One of you must answer the components of a Carter-Jenner syndrome. Anyone?
The component.
Just a minute.
The components are.
Piyush, yeah, go ahead.
Components are situs invertus, bronchiectasis, and sinusitis, sir. Because of the decreased ciliary functions, there is a azoospermia, sir, in Carter-Jenner.
No. You have to explain a little better, Piyush. Because immotile cilia syndrome, how it gives rise to azoospermia. Anyway, Dhananjay Kumar, come in, get exposed. These are the stimulus, these are the inputs that you need to have. Vikram Haldar. Are you still there?
Is coming?
Piyush, anything else you would like to add?
Professor Hota, please explain.
No.
You
What
are
I'm
expert.
telling,
Explain.
no. What I'm telling, that's the reason I said, na, you are now the master on this. You are the master. You have asked the question. Will explain. Just I was giving them a hint that this is a infantile cilia syndrome affecting multiple organs. Now, please explain. Unmute yourself.
We students try one of the exercise from our teachers.
Yeah,
That's
Rajendra,
always.
unmute yourself, Rajendra Singh.
So morning. That's always.
Hello. So for this spermatozoa to come out, no, the ciliary movement is required. As the ciliary function is not there, it cannot come out. Understand? It cannot. So that's why the azoospermia is there. Next question to the student: how will you manage the man wants to make pregnant with his sperm? How you make him pregnant? How with his own sperm? In such a situation.
I think let us make it little elaborative. This man is not.
Let them answer. Let them. How you help them? How will you help them? They are not able to. They are infertile, unprotected sex for last 2 years. How will you manage? This is a case of Qatar.
Yes, Piyush, you are answering well. There's so many, you know.
Why our students are not answering?
Yeah. Well, yes, Piyush.
What is the full form of TC? TC Mesa. Tell me what is the full form of TC?
Rajendra, just wait. Piyush is answering about the second question that you had asked. You can unmute, Piyush. Or Sachin Patel, Sandeep Manna. Ishans, so many students are there. Don't feel shy.
Come on, you come. Why you are keeping quiet? In the exam, you are keeping quiet. Prognosis is very bad. In the class, all right, in the lecture class, but in the exam, if you are not answering, the prognosis outcome will be very poor. What is the full form of MESA? MESA. What is or TISA? TISA. Professor Hota, they are not hearing me, or I don't know why.
No, they are hearing, but they are feeling shy. Can I call in Dr.
Why should they feel shy? This is the learning procedure. I am learning from you. I am learning from them. I have learned.
I believe they are all tired. It's Sunday also, midday. So leave it. I believe we'll wind up the session here.
Let's do like this. Let this question be asked. Let them answer later on. But the questions Rajendra Singh has come prepared. You just ask a few questions. 1, 2, 3. Tese mese you have already told about.
Sir, can you hear me, sir?
Yeah, Piyush.
Am I audible, sir?
Yeah.
Piyush,
the tese is testicular.
Come on, Piyush. I am hearing you.
The tese is testicular sperm extraction, sir.
What is PESA?
The testicular TESA is the testicular sperm aspiration, sir.
No. PESA. P for Puri. PESA.
PESA is percutaneous sperm aspiration.
No, little more.
Percutaneous epididymal sperm aspiration.
Okay, let me highlight on that. You know, that is a procedure that you can do in your clinic itself. Well, how do you go for a PESA?
But we have to we puncture epididymis percutaneously to aspirate the sperm, sir.
So where from you aspirate? What
From
are
the,
the what are the what are the steps? I don't want to go to the steps. Let me ask a very pertinent question. Where from you aspirate the sperm in PESA?
From the tail of the epididymis.
No, not tail. Why tail?
Because mature sperm will be present, sir, more distally, sir.
Why do you require mature sperm? See, that is what exactly was taught to you earlier. Spermatogenesis and spermiogenesis. That is the word that was told to you. But why do you want it from the tail? Because possibly you haven't seen a PESA, isn't it?
No, sir.
Yeah. So remember, PESA is utilized for the purpose of artificial reproduction technology, particularly for ICSI, IVF and ICSI. Am I correct?
Yes, sir.
So not for the routine AIH. It is not for AIH. Normally AIH is not possible with a PESA. It is only for the IVF and ICSI, isn't it? And for that you don't require a tail sperm. That is one. And secondly, the tail sperm, you aspirate the sperm from the epididymis, from the tubules. You know that epididymis is a convoluted long tubules. So you aspirate from the tubule. The success rate is around 50 to 60% depending on the distensibility of the epididymis tubule. So you always aspirate from the tubule, whether it is tail or body or the corpus or the head. Doesn't matter. So PESA is a technique which you can perform in your clinic itself for the purpose of IVF and ICSI. Yes, Dr. Rajendra.
Yeah, thank you, Professor Ota. Next question. How many convoluted tubules are there in epididymis? Answer, Pius. How many convoluted tubules are there in epididymis?
Tougher questions.
Pardon?
Tougher question, tough questions.
Yes.
Anyway,
these are only one.
These are the food
There's
for
only
thought.
one.
These are the food for thought. If they are not answering, allow them to go back, read and come back. Now, next question.
Very good. Professor Hota is telling you people to read. You are final year, so now you must read. Why the external meatus is vertical in disposition? Why the, I repeat the question. Why the external meatus of urethra is vertical in disposition? Pius, answer. It is given in Campbell. This is because the urethra in the proximal bulbar and is round, and in the external meatus is a vertical. It is for proper mixing of the semen with the spermatozoa. By rotating like that, spiral, the mixing is better. Understand? That is the reason why it is vertical. And when you do hypospadias surgery also, we aim to achieve that, but very difficult. Yes. What is the smell of semen? Next question. What is the smell of a semen? Typical description.
Fishy.
Yes, very good. Why this? Why this? Who answered that? Who answered?
Who answered that? Come in, come in. Be very prompt.
Name, your name. I want to hear who is that? Who answered?
Yeah, gentleman from Galaxy. Galaxy.
What is your name? You people are not very sporty. I ask you, but you are not answering. So, this is because of the aldehyde present in the semen. Aldehyde. Next question, what is the function of epididymis? Use, what is the function of?
Rajendra, just a minute.
Sir, both sir, transport of sperm and the maturation of sperm, sir.
Any other word you want to use?
Storage and motility.
Capacitation is the word you should have used. Capacitation.
Yes, yes,
Yeah.
Professor,
Yeah.
Professor Hota has given you. If you answer that, you get good mark. That is what we want to come out from you.
I will invite one person to answer. Now I think I must invite Vikram Haldar. Don't feel shy, just unmute your audio and video.
Then I put question now, that is all. Next question. I already explained what is concord deformity. Answer. You have seen about 20 minutes ago. What is that? Concord deformity.
Sir, because of short, sir, prosthesis, sir, the glans penis buckles down, sir, like a concord, tip of the concord plane, sir.
Very good. So you have to select proper size, like you have to trim in the case of the Saha prosthesis. Yes. When you do injection therapy, injection for the ED, the most severe complication, there are a lot of complications like the hematoma, so on. What is the most important severe complication?
Priapism.
Pardon?
Priapism.
Yeah, good. How will you manage? How will you manage? Patient come with a priapism.
So in those patients where it is already advised to use intracarbonaceal injection, I will always tell him that there is a probability of having such complication. So he should attend hospital as early as possible. And sir, aspiration.
He has come to you. He has come to you. How will you manage? Question was, he has come with a priapism. How will you manage? That was the question.
Sir, first I will try to aspirate.
Vikram.
So aspirate and irrigate. Aspirate and irrigate.
Yeah, Vikram.
Yes, sir. Yes, sir.
Just please wait. I think there is a catch to the question.
Okay, sir.
Whenever there is a question asked to you, see why the question is asked. So you have counseled the patient about every aspect of a ICVAD. Am I correct?
Right, sir.
Yeah. Now, when do you intervene? Time of intervention is very important.
So if the erection persists more than 4 hours.
There where you are faulting, you know. Don't wait till 4 hours, right?
6 hours.
No, not 6 hours. Can anybody answer up to what you can wait? You know, there are two types of things. One is a testing, other is a therapeutic use of ICVAD, right?
Yes.
Now, when we talk about testing right in your clinic, you know, the gentleman is there, right? Suppose you find the erection is persisting for more than an hour, get alert. Do you get my point?
Okay.
Don't wait. The classical teaching of a priapism for a painful persistent erection beyond 4 hours, that definition doesn't hold here. You get my point or not? This is a persistent rigid erection. Don't allow the penis to be remain erect for 4 hours, then intervene. Because this is a testing situation. The patient is right in front of you. Right?
Yes, sir. Yes.
What you do, you look whether there is any determinations or not after you have chosen the lowest dose and the patient has developed a priapism. Right? So in that situation, you ask him to do some, maneuvering. Suppose it is 1 hour. Many a time the person goes and voids if he is out of the stimulating situation because we ask them to fantasize. So you de-stimulate him, ask him to go out, ask him to void. Many a time there may be determinations initial part. But despite that, if that doesn't occur, you wait for half an hour, 40 minutes. Then you give other agents. but beyond 2 hours, don't allow, right? Have you used phenylephrine? Vikram? Hello?
Yes, sir. We have used, sir.
What time you intervene in your protocol?
So most of the time, so in our setting, we do not get patients coming immediately after they had this priapism after 4 to 6 hours. They usually come after at least 2 to 3 days or more.
No. I think you have not got my question. In the testing, when you are performing a ICVAT testing to know about the erection, if there is an erection persisting beyond what hour, you intervene.
So actually, we don't have any practical experience regarding that.
Okay, anyway. So the best part is that don't let the patient go unless there is a determinations. And if you find a persistent erection for 2 hours and there is no sign of determinations, better intervene there. Don't wait for 4 hours. Right? This 1 to 2 hours is the window period at which you should intervene. Otherwise, you have to do all the procedure of a management of a regular priapism. Right?
Yes, sir.
Okay. Next, sir.
Yeah, just continuing the quiz. Name some of the shunt you know of. Name some shunt which are used when all your aspiration. You have to do some shunt. Tell us some shunt you know of. Haladhar, where has he gone?
Vikram is there. Is there? Very much there.
Yeah, Vikram. Name some shunt you know of. 1, 2, 3, 4. I don't know. Have you heard of winter sun and all those? Sepino femoral naam kya hai? Paro. You have to read all these things.
Winter,
Okay.
Ebehoz, T-Sunt.
Asutosh.
Yes, sir.
Do you go for a T-shunt or a winter sun in case of a drug-induced priapism when you are testing? I want to highlight on this.
Sir, don't have any personal experiences regarding that.
So these shunts, when the patient present with the priapism at the latter part, but when you are doing an ICVAT and having a priapism, since the patient will be with you, normally those shunts are not required. Okay.
Yes, sir.
Let me ask, adding to what Dr. Rajendra Singh has told, if a person has erection more than 2 hours,
Professor Hota, please repeat. Benefit of everybody, just repeat.
If a person you have tested for his potency with an ICVAT drug, like
we can't hear you.
Am I audible now?
Your signal is poor, I
Yes,
suppose.
you are audible. But, go ahead.
I think Rajendra is not hearing. Anyway, Asutosh, let's come back. Well, if a person has an erection for more than an hour and there is no sign of detumescence, you don't plan for a shunt at all. You plan for management other than shunt in the initial part. You try, you try with phenylephrine. Then you go for the injections, irrigations. Usually they give rise to detumescence. If those things are not helping, then external extended drainage you do. Right? You do not think of a shunt in a case of drug-induced, untesting drug-induced priapism. You go for an extended external drainage, cavernous drainage. This is the standard protocol. I think sometime we'll have a discussion on this.
Phenylephrine is not available, even adrenaline can be used.
No, adrenaline, I think adrenaline is a drug that we are using earlier. If
It can be also just for the students here. This
100%, 100%.
What is the first step? Phenylephrine or just irrigation?
Yeah, please. Coming back, Dr. Misra.
Can I ask you, what about the status of the Tarbutalin tablet in the initial?
No, see, those are anecdotal. Those are anecdotal. They have not worked, right? So there are many drugs has been tried. but they hardly work. But the best policy is that you don't allow the erection to remain beyond 2 hours. So the earlier you intervene, chances of success.
Just drain it 50 cc of blood from the cavernous.
No, nothing is required. If you just have phenylephrine, if you inject, usually they respond. If they do not respond, if you have adrenaline, you can use the adrenaline, but adrenaline use has to be very, very careful. You have to.
1 milligram in 20 ml.
Yeah. So one has to be extremely careful. 0.1 ml and make it 1 ml. Then you start injecting.
Yeah.
So that is how. Then I think the best part is that if these two are not working, go for an external cavernosal drainage, extended cavernosal drainage. Then about 100 ml of blood. And then you can again inject phenylephrine and keep it compressed. They usually respond. So don't allow a patient to leave your clinic unless there is a detumescence. That is the catch. That is the
What's
catch.
the dose of phenylephrine?
200 microgram per ml.
Yeah, 100 microgram. You start with a lower dose, and you can
100 to 200.
Yeah, you can increase it afterwards. Now, next is Dr. Rajendra. Where are you? You have disappeared. I think we should.
I'm here. I'm here.
Yeah.
What next question? What is next question? What is stuttering priapism?
Stuttering priapism.
Yeah, next
Stuttering
will be
priapism.
Prashant Chaudhary. Prashant, come forward.
So now the students will say, "Bacche ki jaan loge kya?"
So it is recurrent priapism seen in cases of sickle cell disease.
This will be the Prashant. No, just a minute. This is the last question. We'll conclude after that. Prashant.
Yes.
Your call now.
Yes, sir.
Sir,
audible?
Yeah, we are.
Yeah, you're audible.
Yeah, we are audible.
Recurrent question.
Dr. Hota, I will leave for a minute.
I think we should conclude. This is the last one. Because Rajendra make always everything interesting.
Right.
Thank you. Stuttering priapism, I was asking. That is takes off and on. Priapism comes. That usually occurs in
basically
sickle cell
traumatic.
anemia. You have to use the drug sildenafil, the one which produce erection. Is a like using heparin in the disseminated intravascular coagulation. Here also we use sildenafil as a molecule of choice for the management of stuttering. Thank you, Professor Dr. Chor and the Prashna, Nandi, everyone.
Thank you, everybody.
Thank you, sir. Thank you.
It was a very good meeting, and we had a nice time. We had lovely discussions.
But before conclusion, I have got an appeal again to all. Rajendra Bas, you also remember, I am organizing. The USA Andrology subsection is organizing a CME, first CME on 10th and 11th of September. Dr. Misra, also you please join in the subsection.
I'll block right now. I'll block the dates right now. Thank you.
So please join.
10th and 11th. 10th and 11th. Note down.
10th and 11th September, Konark. The place is
Konark. Yeah, lovely. They cannot be registered for andrology.
Jai Jagannath. Thanks a lot to all of
Thank you, everybody. Thank you, everybody.
Yeah, and wishing to meet you at Konark. Thank you.
Thank you, sir. Thank you.
Bye-bye. Bye-bye.
Namaskaram.
Namaskaram. Nandi.
Thank you, sir. Thank you.
Thank you. Okay. Was.